You have to mute.
Hi, Vidya.
Hello, Dr. Bhaskar. Welcome.
Hi. What time
Good
will I be
afternoon,
required?
Dr.
Around
Sir.
4. Hi, Sarita. Hi, Dr. Archana.
No, you address and then
Sir.
now we will start our program and we will welcome you. And then
We'll start at 4, no?
No, we are starting early.
Okay.
We are taking your addresses.
After the welcome and chief guests and guest of honor addresses are between 3:45 and 4, and at 4 o'clock we are starting the scientific and
Okay.
the pre-test.
Excellent. Okay.
Yeah, so right now.
Vidya ma'am, can we
I
start?
think we can go ahead and start.
Go ahead, Dr. Meena. Nilima, start. Please start.
So, I would like to welcome Dr. Sarita Madam, Nandita Madam, Bhaskar Pal Sir, Vidya Madam, Kavita Madam to the Urogynec ICOG certificate online course on pelvic floor. This is the third day of the course. Now I request Sarita Balaram Madam to give the welcome address.
Thank you. Good evening, Dr. Nandita Palshekar, our guest of honor, Dr. Bhaskar Pal, ladies and gentlemen. I'm delighted to welcome you all to this final day of the FOGSI ICOG certificate course on pelvic floor. This is the 8th course that we are having this year. We began with PPH, obstetric emergencies, then we had cosmetic gynecology and endometriosis, then we had infertility and adolescent gynecology. Last month, we had lactation, and this is the 8th course. And I'm delighted that the attendance has been slowly increasing. And this time we have 1,135 candidates registered for the course, which is really a very, very good number. I'd like to thank Dr. Jaideep Tank and Dr. Madhuri Patel for giving us this opportunity to conduct the course. I'd like to thank our ICOG office bearers, Dr. Parul Kottawala in particular. It was his idea that we should have a dedicated course on pelvic floor with urogynecology and with prolapse. And it's really very good that FOGSI and ICOG has taken this initiative to showcase the kind of talent right across the country. When I spoke to the conveners, Dr. Kavita Barnwal, Dr. Suman Sinha, and Dr. Vidya Thobi, without hesitation, they agreed to take on this mammoth task. And they have done everything from 0 to 10, including the topics, the speakers, the coordination, and everything. My thank you to them for this wonderful work. I'd also like to thank our coordinators, Dr. Meena, Dr. Niharika, Dr. Meera Raghavan, because I know that it's a big responsibility, and with a busy OPD and obstetric commitments, to commit this kind of time is really very, very commendable. A big thank you to our faculty, speakers, and chairpersons. I know that I'd like to apologize that we are giving our speakers only 15 minutes to speak for a presentation that probably has taken them 15 hours to make and probably encompasses 15 years of hard work. But apologies for that, but thank you so much for participating in this program. These ICOG certificate courses carry 10 points for each successful course. And a message to all the attendees is that once you have 100 points, you are eligible for MICOG, you are eligible for FICOG. And this year we have two convocations coming up. We have the ICOG annual conference in October in Ahmedabad, where we are going to have a convocation. And we also have another convocation in Mumbai in January. So please do log on to the ICOG website. Please have a look at the requirements for the MICOG and the FICOG. And I encourage you all to become fellows and members of the ICOG. With that, I'd like to end my address, and I think that these courses will go a long way in encouraging our youngsters to pursue urogynecology as a subspecialty. Thank you very much, and back to you, Dr. Meena.
Thank you, Sarita Madam. Can I request ICOG team to play the CD? I request,
please don't bother.
Meena, we can introduce Bhaskar sir. We will
I don't need my, please don't bother.
Nandita madam, just I will introduce, okay?
Bhaskar, we want to introduce you.
Yes.
Yeah. So I think sir has, doesn't need. Yeah.
introduce Bhaskar
thank
Pal, sir.
Yeah, thank you, Meena. So great coordinator and working so hard to make this program wonderful and so meaningful. So it's my honor to introduce Bhaskar Pal sir, though he doesn't need any introduction. Recently, sir has won with great margin the President FOGSI, that is prestigious post. But
That is
just
enough.
his
Dr.
customary-
Kavita, that is enough. That is
Yeah,
that
okay.
is enough.
Sir,
Kavita.
you okay, senior consultant?
Yeah, yeah.
For
Okay, okay.
Don't
That's
your
fine.
person endoscopy
That's
committee.
fine. That's
Dr.
fine.
Bhaskar,
Okay,
we
okay,
will
This
sir.
fine.
Immediate
you.
past person
I
IG,
have been
relative to
introduced in.
support.
It's okay. It's okay. I've been
Chairperson
introduced.
Organizing Committee ICOG
Dr.
23
Kavita,
Kolkata.
please,
Sir, I have in my mobile
please
also.
leave it. Please leave it.
Sir,
Bhaskar, now you
mobile also
learn to hear
continues
this
typing.
every time.
And
I've
clinical
been,
examiner, MRSOG Part 3, sir, is author of more than 40 papers and book chapters. So with these words,
thank you.
I
Thank
just
you very
sir
much. Thank
belongs
you.
to from our zone, East zone. So really, I'm very much proud of him, and I request with great honor to give the blessings and to say.
Thank
So
you.
he
Thank
is
you
the
very much.
president of all the zones.
Thank you. Thank you very much for the kind introduction. And at the outset, I'm deeply honored to be invited today as the guest of honor in this program. I congratulate Dr. Parul Kardawala, Dr. Sarita Bhalerao and team. And I'm really delighted to know that this is the 8th course that ICOG has conducted. I think ICOG is the academic wing of FOGSI. While FOGSI does a lot of academic work, ICOG also does a lot of academic work, and it is in synergy we can do a lot. And I think these courses are a great way of making sure that people learn and also ignite interest in the youngsters. Urogynecology and pelvic floor is very important given the fact that our life expectancy in India of women is such that at least 1/4 of their life they will spend in the postmenopausal state. And that is where urogynecology and pelvic floor assume significance. And I think we need to train more and more people to address the urogynecological pelvic floor. And also moving ahead, I would think that this will move on to geriatric gynecology as well. I'm a great fan of collaboration, and it is great to see that 2 committees of FOGSI, the vaginal surgery and the urogynecology, collaborating, Dr. Suman Sinha and Dr. Kavita Banwal, my dear friends, along with Dr. Vidya Thobi, Vice President-elect of FOGSI, and not my Vice President. FOGSI is Vice President for the year 2026 as the coordinators. And again, it is delightful to know that these courses have evinced so much of interest that we have more than 1,000 participants. So I wish you all the best going forward. And once again, thank you very much for inviting.
Thank you
Thank
very
you so
much.
Thank you,
much,
sir, for your kind words and blessings. So, yeah, okay. So, thank
Now
you,
I
sir.
request,
Please stay if you have time so that we can have a few sessions.
Now I request Vidya Madam to introduce the chief guest, Dr. Nandita Palshetkar Madam.
Dr. Nandita has not joined yet, but I think whenever
Can we wait, Madam?
she will join, we will definitely
Madam.
take her blessings.
Okay.
Yeah.
Madam,
Yes.
introduction of Sheila Mane, Madam.
Dr. Sheila Mane Madam had addressed us yesterday, and if she
Okay,
had joined
madam.
today also, definitely yes, in concluding remarks or as expert comments, we will take from her. And even Dr. Parag Biniwale, if he had joined, he can give us expert comments at the end. So today we have got a galaxy of speakers, and I welcome all the delegates who have joined. At exactly 4 o'clock, we are going to start our pre-test. And to tell something about yesterday's recap, I must tell that we just discussed the genital prolapse. We started yesterday with the genitourinary syndrome in menopause, which is usually unspoken suffering of most of the postmenopausal women. And it was suggested to ask leading questions to the woman who comes to your OPD. And most of our gynec OPD, if you say, see, they have got various problems, especially in the perimenopausal period. And definitely these 3 days, we are addressing all the problems of perimenopausal women along with all the factors related to the genitourinary syndrome. And also, we discussed about the approach to prolapse, how to assess the prolapse, what is anatomy and everything, classification, and the clinical presentation, etiopathogenesis, everything was discussed, and most emphasis was given for the prevention of prolapse. And definitely we have to, whenever we just teach in theory that Kegel's exercise and everything, so that also was explained in detail, and especially in the postpartum period. And there were newer modalities to treat prolapse conservatively, including various pessary options. That was a nice talk, was on pessary, and the ultrasound in prolapse was also discussed, and how we have to enhance our diagnostic modalities by use of ultrasound. The pregnancy complications with prolapse in gravid uterus was also a talk yesterday, and various options were discussed about the pregnancy and prolapse. What are the conservative surgical options for vaginal hysterectomy? There were beautiful videos, demonstration of various surgical procedures, and vaginal approach to the wall prolapse and colpoclysis in the older woman. That was also discussed. So these videos and various surgical procedures are, as yesterday link was given, you can just observe on YouTube also. Now today I welcome all the chairpersons, all the faculties who are here to deliver to their best. I welcome our chairpersons, Dr. Ashok Kumar, Dr. Kiranmai Devainani, Dr. Sneha Buyar, Dr. Ashwat Kumar, Dr. Pratibha Singh, Dr. Archana Jha, Dr. Rekha Jha, Dr. Leena Nair, Dr. Bharti Maheshwari as chairpersons, Dr. Pranay Shah, Dr. Mohan Regmi, who is an international speaker from Nepal, Dr. Shrikala Prasad, Dr. Vijay Kumar, Dr. Raj Maheshwari, who is very stalwart in urogynecology, Dr. J.B. Sharma, Dr. Amita Jain, and Dr. Karishma, and Dr. Ramani and Dr. Dheera. All are their expert and in their own field, and they are going to tell us something what they know. I welcome Dr. Nandita, who is here, and we all know her. And I welcome you, madam, here to the academic wing of ICOG. We are conducting 3 days course on pelvic floor, and more than 1,000 people have registered, and they're gradually joining us, and they're waiting only now for pre-test. And we are just knew that you were busy in the surgery. So we need your blessings on this platform. Welcome, madam.
Thank you, Vidya. I think ICOG is a fantastic place, and I must congratulate Parag and Ashok for doing a great job. Pelvic floor is so important, and the fact that 1,000 plus people have joined, Vidya, I think it shows that how much people are interested in it. And like I attended the OSS workshop of the RCOG and FIGO, and it was very interesting, very good to know what is happening, especially in UK, where a lot of midwives are delivering and all that, and where the things are different. So I feel that in India, our problems are probably different from theirs. And the fact that we are looking into it and conducting such a beautiful certificate course, I think I must congratulate. And Kavita, thank you for following up and inviting me here. And I can see Dr. Bhaskar Pal. Good evening, Dr. Bhaskar.
Good evening.
Select. So happy to see him here. And I'm not taking everybody's name because I think Vidya took everybody's name. So it's just a pleasure to see everybody.
Because the people in between come and go in the audience, so let them know the faculty. That's what. There is a time also, 2 minutes. Yeah.
And Sarita, thank you for inviting me over here. I think it's wonderful program. Thank you. Thank you very much.
Thank you for joining.
Thank you, madam, for joining, for sparing time for.
Thank you, madam.
Welcome.
Thank you for your blessings.
Yeah, I can see
Madam.
Neha also. Kiran is there. Kiranma is there. I should reduce.
Dr. Sarita, our secretary, ICOG.
Secretary,
Hi, thanks, Nandita, for joining.
thank you.
Thank you.
Now, can we go ahead with the pre-test, madam?
Yes. Please tell the guidelines for Dr. Meena about the pre-test.
So pre-test will be projected as a QR code, which you can screen, or it will come as a Google form in the chat box, and you can click on it, and there will be 10 minutes time. We can do the pre-test. There will be 20 questions. You can answer all of them. At the end, the same questions will be displayed as post-test, and you can answer, and 50% of the marks should be scored to get the ICOG certification. So now you can screen the QR code. ICOG team, can you display the QR code on the Google Sheet? Thank you. You can see, check the chat box.
Chat box, and in the chat box also there is a link given. Okay. So please attempt, and there is a time has started now. 2 minutes left. Please complete your pre-test.
Only 1 minute is left, madam. 1 minute is left for the test, less than 1 minute.
Thank you. Now we go to session 1. We would like to invite the chairpersons for the first session, Professor Dr. K. Sita Lakshmi, Dr. Kiranmai Devani, and Dr. Sneha Buyar.
Dr. Meena, please introduce in 2 lines all the chairpersons.
Yes, madam. Yes. Professor K. Sita Lakshmi is the retired dean from Virudhunagar Medical College, and now she is a urogynecologist, HOD at Savita Medical College, certified urogynecologist with special interest in POP, especially wall prolapse and urinary incontinence. Next, Dr. Kiranmai Devani. She is the chairperson, FOGSI No to War Committee, vice president, OGSH Hyderabad, 4-member FOGSI No to War. And also she has got many accolades. Kamini Rao Yuva FOGSI Orator, FOGSI Veera Award. Next. And Professor Sneha Buyar, who's got International MS Signature Award for Phenomenal Leadership 2020, Asia GCC Award 2021, and many awards to her credit. Adding further to the cap, and over to the chairpersons to introduce the speakers. Now I invite Kiranmai Devani Madam to introduce the first speaker, Dr. Pranay Shah. Over to you, chairpersons, to take over the session.
Thank you, Dr. Meena. My regards to all the seniors here, Vidya Madam, Nandita Madam, Sarita Madam and all. I think it's a wonderful course. I'll not repeat again, but very, very nicely crafted program with all the experts in the field. So without further delay, let me introduce the speaker for this session, the very first session. Dr. Pranay R. Shah is a consultant gynecologist and endoscopist. He's a course director, gynecology, IMMAST. He's graduated from Seth GS Medical College and trained in endoscopic surgery in Germany. And Dr. Shah has performed more than 25,000 endoscopic surgeries since 1994 with special interest in FEES, endometriosis, and urogynecology. Trained in robotic assisted laparoscopic surgery. He's a teacher, coordinator, and faculty for MIS MUHS fellowship in Vadia Maternity Hospital. And as you can see from his wonderful CV, that he's a teacher, trainer, and an expert in the field. So let's hear Dr. Shah speak about post-hysterectomy BVF. Welcome you, sir. Over to you.
Can you hear me?
Yeah.
Should I share the screen? I think.
Yes, yes.
You are able to see the screen?
Yes, yes. We are able to see your screen.
Yes, yes, you are sharing the screen. Yes, we can see, sir. Very well.
Thank you. So at the outset, I would like to thank the ICOG team for inviting me to talk on this post-hysterectomy vesicovaginal fistula repair talk. We know that obstetric fistulas are usually because of prolonged labor and occur in developing countries as compared to a gynec fistula, which are usually because of a surgical injury and are more common in developed countries. Harki Siren et al. Described 142 urinary tract injuries among 62,379 hysterectomies, a rate of 1.3 per thousand, and laparoscopic hysterectomy was twice as common to cause a bladder injury as compared to abdominal hysterectomy, and 10 times more common as compared to vaginal hysterectomy. Urinary injuries are also common during the incontinence procedures and the pelvic repair of prolapse. The cause is usually a direct injury to the urinary tract during surgery, which goes unrecognized and not repaired, or devascularization due to use of electrosurgery and blunt dissection instead of sharp dissection. The risk factors involve previous pelvic surgeries, especially lower segment cesarean sections, PID, previous pelvic radiation, endometriosis, and obesity. Post-surgical fistulas usually present within the first 14 days after the surgery. The usual presenting symptom is a persistent, insensate urine leakage from the vagina. If the fistula is small, it may be intermittent and it could occur only during certain positions, such as, sorry, my screen has gone away. Just a minute. Are you still seeing the screen?
We can see the Zoom screen.
Yeah, my
you should minimize the Zoom screen so that.
Yeah,
click on Zoom icon.
Are you able to see my screen now?
No, sir. No, sir. It's blank.
Share your presentation.
No. So I think I was trying to change the screen and it's suddenly gone away. Can I share it again?
Yes,
Yes, sir. Yes, sir.
Yeah, going to get it? Yeah. Can you see the screen
yes,
now?
Sir, yes, sir.
Yeah,
Yes,
sorry.
sir.
Yeah, sorry for the interruption. So if the fistula is small, then usually the leakage may be intermittent only when the bladder is full, or when the patient is lying down in supine position, or on coughing or Valsalva. The diagnosis is usually made on local post-speculum examination when a urine pool is found in the vaginal vault, as most post-hysterectomy fistulas are located high in the vagina. Vagina should be assessed for edema, necrosis, and inflammation to determine when is the best time to operate. In case there is a doubt in diagnosis, the fluid can be collected and it can be sent for urea and creatinine analysis, or the bladder can be filled with methylene blue to see if the fluid which is coming out is stained blue. In case of doubt, a 3-swab test with methylene blue or oral pyridium can be given.
Sorry to interrupt.
Yes.
There is an echo.
Please
There is
open two systems.
echo is
From my side or from?
There are two devices. That's the reason the echo is there. You have to close one, stop one.
Two devices? No, there's only one laptop, so I don't know.
So it's okay now, sir. You can carry on.
Yeah. A 3-swab test or a pyridium test can be done to rule out a ureteric fistula, which occurs in about 10% of patients. Cystoscopy and vaginoscopy is usually performed prior to the surgery to assess the size, number, and complexity of the fistulas and its relation to the bladder neck and to the ureteric orifices. An intravenous pyelography, CT or MRI urogram can be performed to assess the kidney function and to assess if there is a hydronephrosis or hydrouretus. The management is conservative if the fistula is small, less than 0.5 centimeters, and usually involves a prolonged bladder catheterization. About 15% of patients would spontaneously stop with prolonged catheterization if the fistula size is less than 1 centimeter. Various other techniques such as curating, electrofulguration, and laser ablation have been tried with varied success. Should the fistula be repaired early as soon as it is diagnosed, or the timing of surgery should be delayed? The decision depends on the condition and the quality of the tissue. If the tissue is pliable, not inflamed, free of granulation, is epithelialized, and the surgeon is experienced, an early repair can be performed. However, patients who are awaiting surgery should have prolonged catheterization till the surgery, and good perineal care should be done. Elderly patients postmenopausal should receive vaginal estrogen, and patients who are malnourished should have a high protein diet and anemia corrected prior to the surgery. Irrespective of the route of surgical repair, the general principles remain the same: adequate exposure and mobilization of the fistulous tract, approximation of healthy tissue in several layers, watertight tension-free sutures, and interposition of healthy vascularized fat flap so that the healing is good. Adequate bladder drainage for about 14 to 21 days so that the bladder is given adequate rest for healing. Majority of the fistulas post-hysterectomy are high in the vagina, small, less than 1 centimeter, and are amenable to vaginal surgery. The advantage of vaginal surgery is the short operating time, less blood loss, less post-operative pain, and a shorter hospital stay. However, if the fistula is large, more than 2 centimeters, has restricted vaginal access, multiple fistula, involvement of the uterus, cervix, or the bowel, and if it needs any ureteric implantation, then abdominal or a minimal access surgery should be preferred to the vaginal route. Vaginal ureteric stent should be inserted if the fistula is within 1 centimeter of the ureteric orifices. Vaginal repair of vesicovaginal fistula is usually done by the Lesgo's technique. For adequate visualization of the fistula, it is important that we put in a catheter inside the fistula and pull it down so that good adequate access is done. This can usually be done by retrograde dilatation of the fistulous tract using ureteral dilators, as can be seen in the video. Graduated ureteral dilators are put into the fistula over a guide wire, and once adequate dilatation is achieved, 8 number or 10 number Foley's catheter is put through the vagina into the fistula and the bladder, and the Foley's bulb is inflated. This allows us to pull the fistula down so that access is very easy. Stay sutures are taken around the fistula, and circular vaginal excision is done. The bladder can be closed in 1 or 2 layers around the catheter, and then the vagina is closed with multiple sutures so that there is no leak. A bladder can be filled with betadine to make sure it is a watertight sink suturing and there is no leak at that time. Foley's catheter is then kept for about 14 days for the bladder to have rest. Antibiotics are continued. In case a ureteric stent has been put in, anticholinergics can be given. If the fistula is large, a classic method of vaginal repair is done where stay sutures are taken, the fistulous tract is excised, the vagina is widely mobilized, the bladder and the vagina are closed separately. In case the vascularity is an issue, a Marcius flap can be inserted underneath. Usually the flap is vascularized and can be placed underneath to give good blood supply to the fistulous area. The abdominal repair is usually done by the O-Connors technique. The bladder is split until the fistulous area is reached. The fistula tract is excised. Usually to help this, the catheter is put into the fistula through the vagina into the bladder so that the tract can be very well visualized. Once the tract is excised, the bladder and the vagina can be closed separately in layers and a omental fat can be placed between the bladder and the vagina to improve the blood supply of the area. Post-operatively management would include antibiotics, bladder drainage with a good size 18 or 20 number catheter for about 10 to 14 days, use of anticholinergics if the patient has bladder spasm, especially if ureteric stents are involved. Before removing the Foley's catheter, a cystogram can be performed to confirm that the bladder is healed well. Since majority of the fistulas are iatrogenic and they occur during the surgery, it is important to prevent these fistulas by good surgical technique. All patients with pelvic surgery should have a Foley's catheter inserted, and the bladder should be mobilized by sharp dissection rather than blunt dissection from the uterus, cervix, and vagina. An extrafacial technique should be performed as far as possible. While closure of the vagina, a vaginal cuff closure should be it should be careful that the bladder is not included in your stitch line. Retrograde bladder filling can be performed in case of the area saying dissection is difficult, so that we can know where is the upper margin of the bladder. Careful use of energy sources during dissection to make sure that we do not devascularize the bladder. In case of injury, the bladder suturing should be done only after adequate mobilization of the injury. A small video here to show a patient who had a bladder injury in a patient with previous 2 cesarean sections. Once the injury is noticed, the bladder is mobilized, a cystoscopy is performed through the injured area, the Foley's catheter and the ureteric orifices are noticed, and we can see that the fistula is supratrigonal. Hence, direct closure of the fistula can be done without any ureteric stenting. In this case, 2-0 Vicryl was used to close the fistula in a single layer with deep bites without any tension. Bladder is usually a very forgiving organ, and if sutured well without much tension, the bladder would heal very well, provided adequate bladder draining is done post-operatively. At the end of the surgery, the bladder is filled with methylene blue to confirm that the suture line is watertight and there is no leakage. A Foley's catheter is inserted. Usually in small injuries, a suprapubic drain is not required. However, it is a complex injury. A suprapubic drain can also be inserted so that we know that the bladder can be adequately drained even if the Foley's catheter is not draining well. Any patient which has a difficult bladder dissection, a cystoscopy should be performed. We normally perform a cystoscope using a 5 mm laparoscope and not with a cystoscope. The bladder is pre-filled using 25% dextrose, which is a viscous solution, and hence the urine can be seen very easily as compared to using normal saline for your regular cystoscopy. The spots can be identified even by a novice, even if you are not a regular cystoscopist. The laparoscope can then be turned around into the bladder to see if there's any bladder injury or if there is any ischemic area or any suture visible, which can be corrected at the same time during surgery before the patient can present with a fistula. Thank you so much for a patient hearing.
Thank you, sir. That was really crisp and useful and very much important for all the practicing gynecologists. Thank you for your wonderful lecture. So in your experience, which type of hysterectomy, I mean, either lap, abdominal or vaginal, where the fistula formation is more commonly?
I am basically a laparoscopic surgeon, so I very rarely do vaginal and abdominal hysterectomy. So most of my experiences is with laparoscopic surgeries. And however, if one is able to check the injury during the time of surgery and repair it, we do not allow the fistula to occur. So I think injuring the bladder is not a sin. Not recognizing the injury and not treating it at the time is a sin.
Absolutely. And as obstetricians, especially catering to high-risk obstetrics, I think rupture we are not seeing much nowadays, but placenta accreta spectrum, where placenta is densely adherent to the bladder, that is one area where we have a lot of bladder injuries can happen, and we all need to be well versed with identifying the injury, preventing, and as well as tackling it.
I think most of the cases are now previous LSCS, whether you do cesarean or hysterectomy. And good knowledge of the anatomy of the vesicovaginal space is extremely important for a gynec surgeon now.
all the future young gynecologists have to deal with post-cesarean hysterectomies nowadays.
Yes.
It's rare to get a unscarred uterus to do a
Yes,
hysterectomy.
yeah.
Thank you so much, sir.
Thank you so much. Thanks.
Thank you, madam.
Over to you.
Now I request Sita Lakshmi madam to introduce Mohan C. Regni. Professor Sita Lakshmi madam. Request the ICOG team to display Mohan sir's CV.
Good evening, everybody. Professor Dr. Mogan is a program director with the Urogynecology Fellowship in Nepal. He is a treasurer in International Society of Obstetric Fistula Surgeons, member editorial board, Nepal Journal of Obstetrics and Gynecology, and he is the national trainer of obstetric fistula in NHTC, Ministry of Health and Population, Government of Nepal, Chief Policy Advisor for Reproductive Health, Ministry of Health, Nepal, and he is a Vice President in South Asian Federation of Urogynecology. Over to Dr. Mohan, who will speak on surgical management of stress urinary incontinence, which is very important topic that everybody needs in this scenario. Over
Thank you,
to
madam.
Mohan.
Thank you, madam. Can I share my screen?
Yes, sir.
Respected chairperson, first of all, I would like to thank ICOG team, Dr. Parul sir and his team, and Kavita madam, and all my seniors for giving me opportunity to talk in this platform. Today, I am going to talk on surgical management of stress urinary
Sir, can you
incontinence.
make it full screen, sir? Mohan, sir, can you make it full
Yes.
screen?
Yeah, okay. Just a minute. Yeah.
Need to close this,
Yeah.
sir. Yes, sir. Fine.
Yeah. So as there are separate talks on warts and autologous link, in this talk today, I'll just highlight on the different aspect, different treatment modalities and their pros and cons, which will be easy so that it guides youngster to choose which options are best for their patient. So remember this condition, remember this talk and this statement by famous Professor Wolf Onstein, who designed TBT. There is no condition or disease that cannot be made worse by surgery. So always be careful while choosing the procedure for your patient. So last decade was full of news and petitions like this. All the petitions for TBT, TBTO, TOT, legal implications, compensations around the world, particularly in Western countries and USA. Why we should talk about this? Because 10% of all women need repair of pelvic floor disorder, and 30% of them are recurrences, increasing number of revision of complications with legal implications. So if you have 1,000 women, 2 of them will be leading to surgery. So this is the sequence. So we have to be careful. It's a huge problem in our society. And success and failure mainly correlates with the experience of the surgery. So if we see different procedure, all the youngsters have heard different kind of procedure, but they come in market overnight and become popular. See, the development of drugs takes an average of 12 years, but a new surgical procedure can come easily over the night and become popular. So be careful while choosing your procedure. What are the expectations of our patient? Most patients are realistic than their surgeon. They want improvement of their quality of life. They want relief of complaint. Sometimes they know more about possible side effects because there's Google and internet supplements everywhere. So they want open discussion of feasibility, limitation, and complications. So be open to them. They can always disagree with you. So what are the different concepts, surgical complaints, concept in stress urinary incontinence? The replacement of pivourethral fixation, tension-free slings, repositioning of bladder neck into the abdominopelvic balance, call for suspension, and improvement of coaptation and intraurethral injection. So I think this is the sequence. These are classic pop, rock, and hip hop for all the procedures that are available. But there is neither a singleton conservative nor a singleton surgical approach for the treatment of female incontinence because the etiology is complex, pathomechanism are complicated. So we have to individualize according to the need of the patient. And we should always remember mainly it's a denervation injury that's because of childbirth women are having and because of lack of estrogen in perimenopausal and postmenopausal period. So you should remember what happens to muscle and nerve density in healthy women and hormonic prolapse because of several etiopathogenic factors. So you have to always respect the heterogeneity of patient group, the severity of complaint, duration of complaint, age of the patient, physiologic history, primary outcome, what outcome you expect, outcome setting, objective, subjective improvement, and how you are going to follow. Of course, complication and reoperation should be openly discussed. And don't try to fix the problem like this, no? So what are the, nowadays everyone is talking about alloplastic things. They are really new strategy with acceptance for almost each and all disease, increasing number of partially serious complications. And we should always question, are there really treatment for everything? So if you see the history, the integral theory and development of tension-free vaginal tape and transobturator tape and Millie-slings came with Petros and Alstein integral theory and designing of the retropubic TVT, midurethral sling. Then cystoscopy was mandated in the procedure. So transobturator sling later on came, which says that cystoscopy is not mandatory, but I always advise everyone to do cystoscopy even if you are doing transobturator sling or mini sling. So TOT was designed in 2003 with similar results in both groups. And now the third generation slings are single incision mini slings placed in mid-urethra and attached to obturator fascia without exit incision. So we are operating in this area and is as portrayed is never going to be easy and not always free of complications. See the neurovascular bundle that is present in that area which you are operating. So there can be different complications of TVT, TOT, the mesh inside the bladder, the mesh in the vagina, and then the pain after the insertion. See the pain, I have compared TVT, TVTO and TOT pain graph with different study. With TVTO, the pain is high. Pain index doesn't disappear even after 4 months, so be careful. So then there are short slings available nowadays. Most of these procedures depends on the expertise of the surgeon. It's very, very important. And this Carl Gustav Nielsen, who was one of the team member of Olmstein and Petros, and who has also published 20 years follow-up of TVT. He has kept a skip line of more than 40 procedure per year, and you see that the complication rates are more when the number of surgery done by surgeon per year is less. As the skip line is crossed, the number of complication goes down. So the procedure should not look like the incompetent surgeon should suddenly find them more competent. So this is one of the complications from TOT, which is published in literature with the hematoma in the thigh, which has been drained, and the result was this after 1 year. Which is published in ICOG journal. I have taken out from that. Always remember the defect. Remember what patient is having. Remember the patient can have other comorbid condition, prolapse, paravaginal defect. So we should always try to find out what kind of stretch and tear patient has undergone because of the different pathognomic factors which I have discussed before. Laxity. So the tear in the paravaginal, you can see the tear comes down like this. Paravaginal tissue, which is evolves from the attachment. You should be always able to diagnose it clinically. It looks like this. It's a normal, and this is the tear, which is often missed. Paravaginal defect looks like this. I have stressed because most of us are not teaching our youngster how to detect paravaginal defect during examination. But now I am going back to Bor's colpo suspension, which was designed by Cooper's ligament urethrovesical suspension for stress incontinence, published by John Borch in 1968. It's a very good procedure. And now it has gained more popularity because in many countries, you cannot put TBT and TOT because the slings are not available because of complications. So now surgeons are going back to autologous sling and colpo suspension. So this is the classic operative field described by Stuart Stanton in his textbook. So there's a comparison between TBT and colpo suspension with the reason a comparable success rate. So colpo suspension focus on elevating vagina, exposing the paravesical and prevesical space, and putting loose hanging stitches, fixing it in the Cooper's ligament. So original Borch, I'm going to describe. You see the stitch, which is more medial towards urethra, and you see the stitch, which is more lateral, which is called modified colpo suspension. In the original Borch, the chances of obstructive voiding was as much as 40 to 50%. In the modified colpo suspension, the chance of obstructive voiding is less. So nowadays we are teaching our youngster doing loose hanging stitch in the paravagina, which causes less obstructive voiding, like this. So this is the difference between the original Borch and modified colpo suspension. It's a subjective and objective success rate, problem with obstructive voiding, which are less in the newer approach. The Borch, original Borch, the modified one is less. So the data I have shared with my professor who has taught me this concept. So alloplastic slings are projected as their solution for everything, but we should analyze the data. And now the colpo suspension and autologous slings are equally coming up. So colpo suspension has emerged as gold standard for surgical treatment of female urinary incontinence. With competition with TBT, colpo suspension will remain the first choice of in all laparotomy. Now endoscopic approach is equally popular. This is the data from 4,500 modified colpo suspension. So what do you do when a mid-urethral tape fails? We take colpo suspension as a salvage, and there are options of autologous sling as well. So colpo suspension is still standard in paravaginal defect, in recurrences, in other region for laparotomy, in young women. But it's not advised in frozen urethra with high morbidity and in hypotonic urethra, and in lack of mobility of urethra. Urethra should be mobile. So in that, I would like to stress on quality of training programs we are having around the world, how well we are training our resident in female pelvic medicine and reconstructive surgery. So this is one of the research published in Brain Journal. You see that even the program directors are less confident in doing different kind of urogynecological procedures. So it is important that we train the teachers as well as the students with this kind of procedures. So I have my own concept, my experience. SUI with serious descent, use tension-free vaginal tape, transobturator tape, or autologous sling. It depends on what you are comfortable, your experience, and several other factors which I have mentioned before. SUI with paravaginal defect, please do a colpo suspension. SUI prolapse, always do a two-step procedure, but we are having a RCT which is comparing one step or two step. And there are several literature now which advise for one-step surgery as well. And multiple failure, go for intraurethral injection, which are very costly. So 25 years from the mid-urethral sling, the lesson learned are they have been shown to be effective and safe, but there are growing concern about safety profile of mesh procedure. Major limitation when deciding a surgical procedure may be the lack or loss of anatomical and surgical skill, and for many medical and paramedical reason, lack of experience. Thank you very much.
I thank
Thank you,
Dr.
madam.
I thank Dr. Mohan for his excellent presentation, and it was very crisp, and he has clearly pointed out which type of SCA, what type of surgery has to be done. And so we should see how we are taking our younger generation in training of urogynecology and female pelvic medicine. Thank you so much, Dr. Mohan.
Thank you, Sita Lakshmi Madam, Mohan Sir. Now I request Sneha Boyer Madam to introduce our renowned Srikala Prasad Madam. Over to you, Madam.
Thank you, madam.
Thank you, sir.
Yes. So a very good evening to one and all. At the outset, I would like to thank the ICOG chairperson and Dr. Parul Kotradawala and Secretary Dr. Sarita Balera. And I would like to congratulate both the chairpersons, Dr. Kavita and Dr. Suman Sinha, and of course the coordinators, the ICOG Governing Council members. It's my pride and privilege to introduce Dr. T. Srikala Prasad. I think our speaker is Dr. Vijay Kumar. Hello. Yes, Dr. Meena.
Hello.
Yeah.
Next speaker. He's the next speaker.
Obstetric fistula by Srikala Prasad Madam.
Okay. Okay. So it's my pride and privilege to introduce Dr. Srikala Prasad. She's the professor and at the Department of Urology. At the government Kilapuk Medical College, and she's the past secretary of OGSSI Chennai, vice president of Tamil Nadu chapter of FOGSI. Of course, Madam has got lots and lots of awards and recognition. The list is endless. I think it will be better if we listen to her. It will be helpful for all of us. So with this brief introduction, I hand over to Dr. Srikala Prasad, and I invite you for your talk. Over to you, Dr. Srikala.
Good evening. Am I audible?
Yes, madam.
Yes, good evening and a warm regards to each one of you. I would like to share my screen. I'm just trying to see.
Yeah. Could you see the icon? Yeah.
Yeah.
Yes.
No, I think I'll make it a screen slideshow. Yes. So after a wonderful talk by post-hysterectomy fistula by Sir, we'll just look into the obstetric fistula. BVF, which is the commonest form of fistula, is an abnormal opening between the bladder and the vagina that results in continuous and unremitting urinary incontinence. So how all? It is usually in the posterior wall, the trigone between the orifices, and in the cesarean section, it can even being seen on the anterior wall or the base of the bladder. The posterior wall of the bladder is inadvertently sutured while closing the vaginal wall, or you can have an incidental cystotomy. Sir was telling bladder is a forgiving organ and it heals beautifully well. But in case the bladder injury is missed and we forget it or we don't see it, it can lead on to a fistula. So you can have a direct injury by cutting, tearing, diathermy, suture, etc., which is recognized and has a good outcome, or an indirect injury either by diathermy or devascularization, which we have not recognized and results in fistula formation. So the most important preventive aspects are to empty the bladder, identify the risk factors, give a meticulous and careful surgical technique. And while we operate on previous cesarean or previous surgeries, you must be careful and enter carefully itself, as the bladder may be there, the entry point itself. Endometriosis and adhesions both alter tissue planes. Suppose we find it very difficult in densely adherent bladder, sometimes we can even do a incidental cystotomy and then go ahead. As I told you, previous surgeries, we have to be very careful during peritoneal entry. Here I am showing a picture of a previous LSCS where there is a gross bladder adhesion. And so inadvertent entry into the bladder during dissection can happen. The take home point is, while you push here, don't use gauze, use sharp dissection. That is the carry home point. When we are mobilizing, opening the UV fold and mobilizing the bladder, in a virgin case, it's very easy. Patient who has not been operated, it just goes in. But if it is a previous multiple surgeries, you can have morbid addition of the bladder and use sharp dissection rather than gauze to push the bladder. This is one case where they called us intraoperatively. Here you can see they have pushed the bladder with the gauze. The anterior wall of the bladder has gone down. The posterior wall of the bladder stays stuck with the lower uterine segment and the Foley is here. So it is in these cases where you must mobilize the lower uterine segment from the lower. See, this is the posterior wall of the bladder. I have separated it from the lower uterine segment. This is the anterior wall, and then you can suture it. Once you mobilize it, then it is easy. As emergency versus elective, you have more number of bladder injuries because of anxiety and altered anatomy in obstructed labor. Placenta previa is one now real problematic condition because of the emergency nature, as well as lower uterine segment being markedly enlarged and vascular with distortion of normal anatomy and tissue planes. See, this incidence is a worldwide incidence. In placenta accreta syndrome, they have about 21% injuries, which is bladder 11.7, ureter 4.7, both combined is always better to be safe than sorry. Here, this was a case of a placenta percreta. It's almost threatening to rupture. These cases, you have to be really careful. Normally, the ureter is not involved in a cesarean section, but it can get involved when there is an angle extension of the LSES wound due to difficulty in delivery of the deflexed head. If it is very difficult, instead of extending the incision, you can put an inverted T-shaped incision. If the wound has extended into the retroperitoneum, there will be severe bleeding. And in case you do a blind clamping in a desperate attempt to obtain hemostasis, you may injure the ureter. In placenta accreta spectrum, when we do a cesarean hysterectomy, ureters are at risk. In subtotal, ureters are not at risk. So when the principles of urinary fistula management, the optimal tissue condition is needed, an adequate vascular supply, you ensure adequate nutrition, eliminate infection, when needed. So I'm just putting a small video. Can you see? This is an abdominal repair. So where we have put in a, can you see? I'm putting a ureteric catheter through the fistula. The fistula, I brought it inside the bladder. Okay, now we are opening up the bladder. This is an open procedure, but we have recorded it through a laparoscopic camera. So this is called a no-conus technique, where the bladder is being bivalved till the level of the fistula. On the posterior wall, using diathermy, down and incising the bladder down to the level of the fistula. How do I identify the level of the fistula? I can see the ureteric catheter. So till the level of the fistula, you bivalve the bladder. Okay, and then you have to separate the bladder from the vagina. So once I trying to separate the bladder from the vagina. So the first is, I put a catheter in through the orifice, through the fistulous opening, then open the abdomen, bivalve the bladder till the level of the fistula, and here can you see I am separating the bladder from the vagina. So all around, patiently you have to dissect the bladder from the vagina, because then you just suture the vagina first. Can you see? Can you see the fistulous opening in the vagina? See, this is a fistulous opening in the vagina, separating the bladder, and we are having the opening as well. Now I start suturing the vagina. Vaginal approximation can be done with 20 Vicryl. Take thick bites. Between the bladder suturing and the vaginal suturing, it is the bladder suturing is the one which is most important. But again, we do a meticulous vaginal approximation. Can you see? So beautifully, I am closing the vagina. Okay, now we start suturing the bladder. Here I've put in a magnifying glass. So now this is the bladder suturing from the inner. Can you see I'm taking the mucosa and a portion of them, suturing it in 2 layers. Similarly, I'm suturing one on the outer aspect also. To the serosa. Can you see? I'm suturing, having 2 different suture materials. One I started from within, from the mucosa, bladder mucosa, and a portion of the bladder wall. The other one I started from the outer aspect. I closed the serosa and the muscle. So I've sutured in 2 layers. Can you see the serosa and half of the muscle? This I'm using the inner one. Can you see I'm taking the mucosa and a portion of the bladder, 1/2 of the bladder wall, the musculature. So I'm suturing it in 2 layers, one from within and one from outside. So that is a suture from the mucosal aspect. Okay. So I'm catching that, holding it, pushing the Foley inside with the distended balloon. Now this I'm suturing it from the serosal aspect. And always we bring the SPC through a separate opening. We don't want to weaken the suture which we have done. So just make a small nick and bring out and then pass the SPC. You can either use a Malicot's catheter or use the regular Foley. Having an SPC and a urethral Foley is like having a insurance. You have, even if one catheter blocks, the other will drain. Now can you see I'm closing it from the serosal aspect. The serosa and 1/2 of the bladder muscle. Then I'll show the continuation from there. See now, okay. Can you see? From the mucosal aspect. Separating nicely and then taking the mucosa. Again ensuring that I'm taking the mucosa and 1/2 of the muscle. So, sometimes it is not very thick and then we can even put it in a single layer. But if it is possible, if you're using a loop, you can have a little magnification. Then you can suture it in 2 layers. Sometimes you find the bladder wall is very thin. You will only be able to take it in 1 layer. So that is also not wrong. Only thing you will have to ensure that you approximate the mucosa and you ensure a watertight approximation. That is what is very important. So there the mucosal aspect suturing I have finished. So I'm completing the serosal aspect. So 2 layers. This is the classical O'Connor's technique. Transabdominal, transperitoneal. After I have tightened that, now we have to fix the all these suturing I'm doing it in bicrane. But the Foley I will suture with the catgut. I'll affix with the catgut because by our two weeks we have to remove the Foley. So I'm using catgut and affixing the anchoring the SPC. Now the next slide, if we have time, we can see, otherwise we can even cut it. So now a cystoscopy is done to assess the fistula. Again, I'm putting a ureteric catheter through the ureteric orifices. This is a supratrigonal fistula you're able to see. I'm putting a ureteric catheter so that I can remove the catheter immediately after I finish the repair. Putting a Foley, and I'm assessing where it is coming from. Can you see beautifully the leak is demonstrated, and I'm able to see the fistula is opening also well. A hydrodissection is a policy by which you can achieve separation of the vagina from the underlying bladder. It helps us easily dissect the two areas. So I do a hydrodissection all around, and then I'm separating the bladder from the vaginal wall. So put an incision, and then because sometimes it, even if it is little high above, you can get it into our field by taking labial stitches. So this labial stitch, I'm utilizing it by bringing the vagina itself. So can you see on all sides, I'm fixing the vagina to the labia. So the whole thing is in our reach. And next will be our aim is to separate the vagina. We have the vagina in our hand. We can easily do a separation. So use curved scissors, sharp scissors, and then separate the vagina from the
Madam, 2
underlying
minutes
bladder.
left for your talk.
Yes, ma. Yes, ma. Yes. You can stop. Already you have seen a vaginal VVF repair. At any time when you want, you can stop. So the main aim is we are separating the bladder from the vagina. That is the principle. We separate the vagina from the bladder, then achieve closure of the bladder first and then the vagina. If you think the conditions are bad, you can bring a Marshall strap. Here you can see that the vascularity is very good. So there's actually no need for any interpositional graft. What we really need to do is achieve good separation of the bladder from the vagina. That is where I was talking about hydrodissection. It really helps us in achieving a good separation. You can do a sharp dissection, some amount you can even use your fingers. So catch the vagina and the bladder and then separate nicely using a curved scissor. So are you able to see? See, I have pushed. I'm now trying to separate the vaginal wall. Now again, below if I found it's not coming well, take one more bite and one more anchoring stitch and bring the vagina to us closer. So all around our aim is to separate. This is the whole surgery. Unlike abdomen, you don't have much difficulty. Here, the main aim is to separate the vagina from the bladder. See, I've started suturing the bladder. If you suture the bladder in 2 layers and then suture the vagina. Depending on the time, we can run or Ina was telling me to move it a little bit. I'll just try. So just suturing. So the post-operative care, IV fluids, antibiotics and analgesics, and anticholinergics will reduce the bladder spasms and help healing. What I wanted to re-emphasize is greater speed will develop by methodical attention to details of technique and by avoiding unnecessary movements rather than by hurrying individual cases. This is, I'm talking of the primary cesarean or the primary hysterectomy. Outcome is more important than the operative time. So carry home, empty bladder or Foley is helpful. Open peritoneum with care at the most superior segment. Sharp dissection is better. Obstructed head or a big baby, inverted T-shaped incision is best. Definitely we need to be conscious of bladder and ureter, but stress or anxiety will have negative impact. When in doubt, use methylene blue. Bladder or ureteric injury patients tend to have more blood loss. Never ever hesitate to call for help. Prompt recognition and repair of injuries should be the main goal. Failure to recognize bladder or ureteric injury is a venial sin, and to miss it or cover it up is much worse and is a mortal sin. Thank you.
Thank you so much,
I hope I
Shrikala
completed within your
Prasad.
time.
Thank you so much for that. Was a wonderful presentation. Very, very practical, very helpful for all not only our youngsters, but all the practicing obstetrician and gynecologists. You've given a very nice practical tips. Definitely in this era of, fast surgery, people count the time. So I think the more time you spend with the patient for the primary surgery, the more meticulous you are, and of course, admit your mistakes, accept them, and try to rectify rather than justifying and just covering up. I think that's a very, very important message from your side. And thank you so much once again for demonstrating all the techniques, surgical techniques required for the vaginal approach as well as the abdominal approach for the ureteric fistula repair as well. Thank you so much, madam, once again. Thank you.
Thank you. Thank you.
Thank you, Sneha madam and Shrikala madam, for the very crisp and excellent talk. Now I request Sneha madam to introduce Dr. Vijay Kumar CR to deliver his speech on minimal invasive surgery in urogynecology. Over to you, Sneha madam.
Yes. Thank you so much. Welcome, Dr. Vijay Kumar, and we are eager to listen to you. He's the MS DNB FICOG and he's got fellowship in urogynecology. He's elected treasurer for BSOG and professor and head of Ambedkar Medical College, medical director of Gynae Care Hospital, Bangalore. He's trained in several, he has trained several postgraduates and undergraduates, and of course, he's got a vast experience in the field of laparoscopy, urogynecology. That's wonderful. So it's our privilege to listen to you on this topic, the minimally invasive surgery in urogynecology. Over to you, Dr. Vijay Kumar.
Am I audible?
Yes,
Yes,
audible.
you are audible.
At the outset, I thank the ICOG chairpersons, FOGSI and Sneha Boyar madam, and the organizing chair committee, Dr. Meena, for giving this opportunity. Is it visible?
Not able to see as a slide share.
Yeah,
Just
you have to
selected.
open your presentation so that the entire screen is shared. You have to open your presentation.
So is it see? No.
No, waiting.
Open the presentation. You click on the presentation.
No, I have done it.
Then I think you need to stop share and share again.
Just wait.
What I would suggest you is you open your presentation first, minimize, then you share the screen.
Right.
Yes, now we can see. Just make it slideshow. Yeah.
Right.
You can put it in slideshow.
Yes. Is it visible now?
Yeah. Just make it slideshow.
Okay.
Slideshow.
Yeah, it's done.
No,
it's not in slideshow.
It is not done, but then I think he may be having some technical issue. Make it full screen.
Yes, now it's fine.
Is it visible now? Hello?
Yes, it's visible.
It is
Ah,
fine. You can start.
Yeah.
Yeah.
So actually, not many of them have ventured into the urogynecology by minimal invasive surgeries. Even now also, I see many of them, they are doing conventional surgeries. There is nothing wrong in doing the conventional surgeries, but only thing is, now this is the era of the minimal invasive surgeries. We have the laparoscopy and robotic surgeries, which are very handy. Not only handy, it gives a lot of advantage to the patients. So in that aspect, today I will be dealing with the minimal invasive surgeries which are done in urogynecology. So as I said, the advantages are many. There are the patient will have less pain since the incision is lesser, and there will be minimal scarring. There will be reduced risk of infection, and even the blood loss will be less, and the hospital stay will also be less. So overall, the though the laparoscopic instruments and the setup will be costly, but for patient overall, considering the number of hospital stay and the number of doses of antibiotic used, it will be overall, it will be cost effective compared to the conventional surgeries. So first I will be going to the laparoscopic sacrocolpopexy. As you all know, it's a surgical procedure done to correct the pelvic organ prolapse. It utilizes the mesh which is fixed to the apex of the vagina, and then it is further fixed to the anterior longitudinal ligament of the sacrum. So who are the ideal candidates for the laparoscopic sacrocolpopexy? Those who are having the symptomatic pelvic organ prolapse, especially the patients who is having the recurrent pelvic organ prolapse, and wherein there is already a failure of the vaginal procedure done for pelvic organ prolapse, and those who desire for the minimal invasive surgery, and especially in cases of the sacroistropexy, is ideal for the patients who want to preserve the fertility or preserve the uterus, and the patients who are younger. So what is the surgical anatomy which is required? As you all know that the presacral anatomy is very important. There will be common iliac vessels which will be dividing into internal and external iliac vessels, and the ureter will be crossing the common iliac artery from lateral to medial. So we will be dissecting the peritoneum just medial to the ureter. So the anatomy, that is the presacral anatomy, is very important, and the surgeon should be thorough with that. So now I'll be running the video. So this is the video wherein I am doing the sacroistropexy. That is, I am fixing the uterus along with the cervix to the anterior longitudinal ligament. So you can see that the presacral anatomy is dissected, the peritoneum over the presacrum is dissected. Here, the care has to be taken that the ureter, which is just lateral to the part where I am dissecting, has to be safeguarded, and ureter has to be visualized completely throughout the dissection. So now the mesh is fixed anteriorly and posteriorly to the cervix and posteriorly to the posterior aspect of the cervix. Here, every surgeon will have a difficulty of suturing. So the surgeon should be thorough with the endosuturing. Then only we will be able to complete the procedure. So after suturing the mesh, then the other end of the mesh has to be fixed to the anterior longitudinal ligaments of the sacrum. This can be done by using the tackers. So these are the metallic spring-like structure which will be used to fix, as you can see here. Then once the tape is fixed, then the peritoneum over the sacrum will be closed so that it is preventing the bowel getting adherent to the mesh. So as we all know that the advantages of the sacro-hysteroplexy or sacropulpoplexy is that it gives the adequate vaginal length and axis. So it is much ideal for the patients, especially those who are younger, to undergo this procedure. So always informed consent has to be taken and proper bowel preparation has to be done and adequate prophylactic antibiotic has to be given. So complications of sacropulpoplexy are there could be mesh erosion, infection, especially the adequate precaution has to be taken to prevent infection, because whenever we place mesh, if there is any infection, it causes a lot of catastrophe. Even there can be vascular injuries. As you all know that the dissection will be very close to the iliac vessels. Even the urinary tract injuries can happen, damage to the ureter and bladder. So we will go to the other procedure, that is the laparoscopic Birch collar suspension. This is as you all know that the Birch collar suspension is age-old method of surgery for the stress urinary incontinence. And of late, we have started doing the laparoscopically. So the recent, there is a short and long-term, the results are out, which tells that the laparoscopic Birch collar suspension is equally effective compared to the conventional procedure. So as I said, it is ideal for stress urinary incontinence, especially when there is hypermobile urethra. And sometimes we can even do it for intrinsic sphincter deficiency. So always informed consent has to be taken, and pre-operatively urinary tract infection has to be ruled out by doing the urinary culture, and anesthetic management has to be proper one. So as you all know that the surgical anatomy, ventrally there is the pubic symphysis, dorsally there is parietal peritoneum, and superiorly transverse facialis, and inferiorly the anterior aspect of the urethra and the bladder, And by the side, we will see the arcus tendinous fascia pelvis. So this proper anatomy has to be dissected before we conclude the vertical suspension. So this is the anatomy wherein you can see that there is a urethra, the bladder, and you can see the pubic symphysis. Along with the pubic symphysis, you can see the white structure, that is the iliopectineal ligament, which is also called as Cooper's ligament. Ultimately, the paravaginal tissue has to be anchored to the Cooper's ligament, that is the vertical suspension. So as you can see that I'm dissecting. Am I audible?
Yes, you are audible. You are audible.
So here the retropubertal space is dissected by pulling the peritoneum. Then once I make a nape, I'll be able to see that the transverse fascia is there. If I cut the transverse fascia, then I will be directly entering into the retropubic space. So that is the retropubic space. We can see that it will be a vascular space, and usually the branches of the obturator vessels will be passing through. So care has to be taken that not to injure these vessels. Now you can see the proper anatomy of the retropubic space. The urethra and the bladder is seen, and the iliopectineal ligament is dissected. Too much of lateral dissection is avoided so that the injury to the branches of the obturator vessels is avoided.
On 2 minutes left for your stop. Hello. Hello.
So once we identify, then the paravaginal space has to be identified, and assistant has to be asked to elevate the paravagina so that a bite can be taken through the paravagina, and that has to be fixed to the Cooper's ligament. In order to identify the bladder, sometimes we may distend the bladder to about 200 to 300 ml so that the bladder will be distended and it will be easy to dissect the retropubic space. Now the assistant is asked to elevate the paravagina. Am I audible?
Yes, yes, you are
Hello?
audible. Yes, you are audible.
Sorry to interrupt you, sir. Your time is up.
Your time is up.
Yeah.
Can we run the videos little more faster?
No, the paravaginal tissue is dissected.
Dr. Vijay Kumar, your time is up and that video is running very slow. So if you can make a summary, that would be good. Summary of your talk.
Vijay Kumar, are we audible? Are we audible? Dr. Vijay Kumar? Dr. Vijay Kumar, are we audible?
Hello?
Hello?
So always 2 bites are taken generally. One at the bladder neck junction, about 1 centimeter lateral to the uretrovesical junction. How to identify uretrovesical junction is when we pull the bladder or Foley's catheter out, you can palpate where is the exact bulb. So usually at the junction of the bulb will be the bladder neck junction, and the bite is taken through that. The suture material used is either the non-absorbable suture, that is the proline, or delayed absorbable suture like PDS 20. So care has to be taken that too much of elevation is avoided. If we cause too much of elevation, then it will cause the voiding dysfunction. So the bladder neck has to be just elevated to its normal level.
Can you summarize the talk as we are running short of time?
So simultaneously on the other side also, the paravaginal tissue has to be anchored to the Cooper's ligament.
Dr. Meena,
Again, in this procedure also,
I think he is not able to
endosuturing plays
listen.
a
You
very
directly
important
call
role.
him.
The surgeon should be very well equipped and well versed with the endosuturing.
Vijay Kumar, as we are running short of time, am I audible? Dr. Vijay Kumar?
Dr. Meena, you call him directly because his video is on. He must have done his audio shut off. So you please call him on his number and ask him to conclude.
So one more suturing has to be done proximal to the prior one. So again, it has to be fixed to the Cooper's ligament. So after doing this, the peritoneum which has been opened should be closed again, and the catheter has to be placed for 48 hours. So patient can be discharged in 24 to 48 hours. So due to time constraint, I will not be able to show the other videos. There will. So in conclusion, minimal invasive surgery is the present era trend, and there are many significant advantages of the minimal invasive surgeries. The short-term and long-term surgical outcomes are encouraging and results are comparable with the conventional surgeries. Robotic surgery gives additional advantages of 3D and dexterity, adding more comfort to the operating room on operating surgeon. So thank you.
Thank you, Sneha Madam and Vijay Kumar. It was a very elaborate talk. Now we move on to the second session as we are running short of time. I would like to request the chairpersons of the next session to take over. Requesting Dr. Ashwath Sir, Dr. Pratibha Singh, Dr. Archana Jha, to take over the session and also introduce the speakers to keep the introduction a bit more shorter. Ashwath sir, President KFOG 2023, Vice President FOGSI 2019. Next, Pratibha Singh, Consultant, Healing Touch Hospital, Bhagalpur, Chairperson IAEC, FOGSI, and many more applause to her, adding further to the cap. Next, like to introduce Dr. Archana Jha, Past Secretary, Box, Bhagalpur, Past Vice President, Box, Bhagalpur, Treasurer, Box, Bhagalpur. Over to the chairperson to introduce the speakers of the next session. Request Ashwath sir. Ashwath sir, are you there? As he is very busy and he is got to join the SOFOG. He was there some time ago. Now I request Pratibha Singh madam to introduce our renowned Professor M. Rajamageshri madam for her speech. Pratibha Singh madam.
Hello. Can you hear me? Can you hear me?
Yes.
Hello.
Yes, you're audible, madam.
Yes. Good evening, everyone. First of all, I would like to thank the organizers, especially ICOG team, for giving me this opportunity to chair this very prestigious session of none other than the legendary of Urogynec, Dr. Raja Maheshwari madam. And to introduce her, she is a professor. She is the head of Department of Urogynec, Chennai Urology and Robotic Institute of OMR, Chennai, Tamil Nadu, India. She is also the director of Urogynecology Research Center in Chennai, India. And her credit, and she has written many books. She has received many awards, and she has been a certified trainer for prevention of and the repair of the perineal trauma. So with this short over to madam.
Hello.
You're audible, madam.
Okay,
Yes,
I'm going to slide share. Slide share.
Share first, madam. You have to share your slides and then make it slideshow. Yeah.
Yes, madam, it's visible.
Okay. Oh. Can you see the slide?
But madam, you have to make it slideshow.
Is it okay now?
Yes, madam.
Okay.
Yes.
Good evening, respected chairpersons. It is an honor and privilege. I'll be talking about urogynecology. What is urogynecology? And brief note about the training. Ladies and gentlemen, what is urogynecology? It is a specialty that deals with the function disorders of the lower urinary and genital tract. What are the problems that are dealt with in urogynecological specialty? Mostly pelvic floor dysfunction, any disease disorders related to the pelvic floor, including pelvic organ prolapse, urinary incontinence, urinary infection, painful bladder syndrome, all these come under the umbrella of urogynecology. It is said that more than 50% of women beyond the age of 35 suffer from some kind of urogynecological problem. So what is the prevalence in the low and middle income countries, the pelvic floor disorders? And it is said that 1 in 4 suffer from urogynecological problem. So regarding the urogynecology subspecialty in India, is it too late or too little? So I'm just going to share quickly a brief journey of how this specialty was established in our country. So the roads that we crossed to establish this. So how we nurtured it and how we advanced the specialty. In the words of Bill Gates, I should say it is an exhilarating, intimidating, sometimes discouraging, and always a challenging task. This is in brief about my professional career development. Because there was no urogynecology specialty those days, I did general urology, MCH urology. Then I underwent fellowship in UK and took charge of the female urology, urogynecology specialty in a government hospital which caters exclusively to women patients. My journey was neither expected nor dreamt, but it's a journey that carried hopes and dreams. What spurred me to specialize in urology? So it is the guilt. Ladies and gentlemen, accidentally, I injured a ureter in my beginning of my career. I was desperate to rectify the damage, and there is no door that desperation cannot open. So guilt is a powerful motivation, and that is what drove me initially to specialize in urology. And still remember the expression of the Faculty of Urology on my first day of residency in urology, as my candidature was completely unexpected. Eventually became part of the team. After my training in urology, I was quite bewildered, confused. I didn't know whether I should continue in urology, should go back to gynecology, or start as urogynecology as a subspecialty. In mid-1980s, female urology, urogynecology failed to impress general urologists in spite of the tremendous scope that the field has in this world of modern medicine. Hence, I decided to continue female urology, urogynecology. And I have rendered 42 years of service in the government and outside the government as gynecologist, urologist, urogynecologist in different categories. I have spent 30 years in the government, state government hospital, and more than quarter century I have spent in the same hospital institution with a vision to develop the best possible female urology, urogynecology unit. All of us who have worked in government hospitals know the burdens and challenges. We have extraordinary workload, and the infrastructure is not adequate, inadequate staff burden, lack of even basic amenities. On top of it, it may not be clean. And there is always an impression that there is no scope for advanced or specialized treatment facilities in a government hospital. I just wanted to disprove it. So I continued my service in government hospital and continue to serve for the deprived and needy patients. Yes, we had limitations. Our amenities were scarce. So at times we have to share our premises with the rodents and cats. And the first task was to improve the basic amenities, enhance the infrastructure to provide a committed service to the poor and needy. So there is a Chinese proverb which says, weave in faith and God will find the thread. Ladies and gentlemen, we served with an objective that government hospital care and treatment facilities are superior, if not equal, to the corporate hospitals. So our mission was to deliver comprehensive quality service, urogynecology healthcare for the poor and needy, with a vision to improve the quality of life of women in our country. We started with providing drinking water, provided dining facilities, improved the toilet. You can see that this is the OT in which I used to operate. Even complex fistula cases were repaired in such an OT with a light which is equivalent to a torchlight. Over time, things changed and we acquired the state-of-the-art theater, anesthesia machine. We even had state-of-the-art aerodynamic evaluation gadgets even in early 90s. Ladies and gentlemen, it was possible for us to upgrade the medical facilities and to serve the least privileged people. It was possible for us to deliver specialized, scientifically advanced treatment, but it took more than quarter century to accomplish it. So we had an exclusive fistula ward because fistula patients were finding it difficult to integrate with other patients. So because ours is a referral hospital, there used to be a regular flow of fistula cases. Most of them are complex obstetric fistula and requiring elaborate reconstruction or intricate surgical techniques. Many of them required repeated repairs. Few of them even required urinary diversions. So we just altered our approach to suit the requirement in our hospital. And we all know that low fistula only are repaired vaginally, but we changed the concept of the approach. Even the a high fistula like supratrigonal fistula, we started repairing by the vaginal approach with a success rate comparable to that. We have created evidence and published it, and our publication highlights the feasibility with a comparable success rate for almost all supratrigonal fistula. So ever since, there is a paradigm shift in the repair approach of supratrigonal fistula from the abdominal approach to vaginal repair. So in 2024, the Urological Society recognized our work and awarded the Chamatkar Award in 2024 UCCON conference. Our work has been cited in the Campbell's Textbook of Urology, and these are some of our citations. The Royal College recognized our center to train their fellows in fistula surgery. So we all know that urogynecological problems are a hidden epidemic with a major health and social burden. But the trained caregivers available were hardly few. So our first task was to focus on teaching and training not only medical graduates and postgraduates, but also to upgrade the skills of the practicing specialists and even to the extent of national outreach program. So ladies and gentlemen, it was possible for us to bridge the gap between the care seekers and care providers by resorting to training. So national and international fellows and trainees started approaching us for training in our department. The first department was officially declared in the government hospital, KGH, in 2005. And the first training center was declared in the same institution in 2007. So that was the only department with the first training center for a country with 1 billion population at that time. So it was possible to reach wider section of needy patients through our fellows and trainees, and training the budding specialist certainly improved their surgical skills and shortened their learning curve. So we used to regularly perform the operative workshop, hands-on training, one-to-one training, and mass short-term training, everything. It was possible for us to spread the specialized services throughout our country. So we regularly conducted the International Urogynecology live surgical demonstration involving the global experts. The global experts who shared our objective voluntarily joined hands with us, and they became part of the faculty department. And it was possible for our local specialists to get trained by them directly. Ladies and gentlemen, complex pelvic floor problems like difficult pelvic organ prolapse were the main surgical demonstration we did. At one floor, it was possible for the local specialist to see the complex pelvic organ prolapse, how it will be operated and managed in United States, how the similar problem managed in European countries, how the similar problem can be managed in the oceanic Australian countries. So that was the opportunity we all had from the global experts who were prepared to share their time and expertise with us. So you see Professor Paul Rees from Austria, and then you see Lenin Vesny from MD Anderson. She's a reconstructive urologist demonstrating the diversion procedures. So we regularly had the international exchange program of learning and sharing. What really has happened with the training? The trained specialists returned to their native states and passed on the benefits of their training to the local needy patients. So one hospital, one center in one state cannot cater to the needy specialized services of 29 states in our country with almost more than 1 billion population at that time. So we just thought it was absolutely essential for us to do the national outreach program with teaching and training program. So what we did is we joined hand with the sister societies like FOGSI and the Urological Society of India, and we have conducted live surgical demonstration, hands-on training, lectures, and academic endeavors as shown have been carried out. We periodically travel down to other states and do this kind of training to the local specialists who are not in a position to come to our center to join the training program. We also managed to empower hundreds of institutions in our country. So it is almost like moving clouds one day and moving the mountains next day. The perineal injury is one of the topic which is very close to most of us. And we all know that 8 out of 10 women who deliver vaginally sustain from intentional or unintentional perineal injuries. Our first workshop was conducted in 2007 with Dr. Abdul Sultan and Rani Thakur as faculty. It was participated by 1,000 obstetricians, and they managed to change the understanding, diagnosis, and management of perineal injuries overnight. Ever since, we regularly conduct in our own institution. We travel down to other states, join hands with the sister OBGY societies, and conduct the perineal injuries workshop, live or video workshops, hands-on training with FOGSI. So, ladies and gentlemen, as said by Gandhi, so what is impossible is not really always so. We also conducted the International Exchange Program and Regional Symposium in our country. It was possible for us to contribute to innovation as minimally invasive, locally, economical mid-urethral slings. And our latest contribution is to the machine learning screening software to predict the bacteriuria in pregnant women. Ladies and gentlemen, we have published an Indian focus, an atlas in urogynecology, contributed chapters to textbooks, and edited menopausal syndrome book. And we have published our scientific research in national international journals, and we have published operative surgical videos to shorten the learning curve of the young doctors. So we have a national society, the Urogynecology Reconstructive Pelvic Surgery Society of India, which is founded in 2005 and affiliated to International Society from 2008. The idea of is to learn and share knowledge and skills. So what is that we accomplished by all these things? Urogynecology is not a mystery anymore, because in 1980s, the word urogynecology is not known to patients and physicians. So the first urogynecology department was founded in Tamil Nadu, which served the patients and trained specialists. So the first department with its training facility and center, it was possible to deliver specialized urogynecological service to every nook and corner, almost all the 29 states in our country.
Madam, sorry to interrupt you. Your time is up.
Yeah, I am just finishing. So the benefits were realized and it is included in the curriculum. So what did we sacrifice? There's a lot of sacrifice for us to accomplish this. Dalai Lama has said it is under the greatest adversity that there exists the potential for oneself to develop and to the society. Ladies and gentlemen, what I would like to show is for the youngsters, don't follow where the path may lead. Go instead where there is no path and leave a trail. So who is defined as a urogynecologist? And the answer is a practicing gynecologist who at least has 50% of urogynecological practice. How is the surgical ability of the trainee is best assessed? It is by the objective structured assessment of technical skills. What is the training duration which is required to call yourself as a specialist? It is minimum 3 years. And how many major urogynecology surgeries a week should be performed to maintain competency in practice? And it is at least 1 per week. What is the ideal number of urogynecologists required? And it is at least 1 per 5 lakh women. So great works are performed not only by strength, but also by perseverance. I would like to thank the organizers, chairpersons, and participants, and good luck. Thank you. Hello?
Yes, madam, audible.
Yeah, I have finished. I have stopped my share.
Thank you, ma'am. It was really mesmerizing. You have done a lot. We heard you many times. You have seen your doing surgeries in various conferences. You are really asset for us. Please keep working, and we will try to teach our juniors for this faculty, urogynecologists. Thank
you. Thank you very much.
Thank you.
Thank you, Professor Rajmaheshwari, madam. Excellent presentation. And now we call upon Archana Jha, madam, to introduce the next speaker, Professor J.B. Sharma, sir.
Hello. Dr. J.B. Sharma, sir, currently working as professor and unit head of Department of Obstetrics and Gynecology of AIIMS, New Delhi. He have many books and he have done many work, awards, and B.C. Rawadi and honorary president by India. And we, sir, we have heard you many times and always eager to hear many times also. And we have read your book also and suggest our juniors. And now today we have a new topic, autologous sling. We are not very much versed with this topic. Sir, please have your time now.
Thank you.
Sir. Thank you.
At the outset, I thank the organizer for inviting me in this and to share dais with luminaries like Dr. Raja Maheshwari, madam. I was listening to your lecture, ma'am. It was wonderful. And I request everyone whosoever is a member of ICOG to vote for ma'am for vice president post. We have already done so. Thank you. Okay. So my topic is role of autologous facial slings in surgical management of stress urinary incontinence. And yeah. So we all know that definition of SUI is defined as by International Continence Society as the complaint of any involuntary loss of urine with activities causing increased abdominal press like sneezing, coughing, laughing, etc. And usually the traditional, I'm not going into detail of diagnosis of SUI, which is clinical, but can be done by urodynamics and examination. And the management is basically, initially we try for non-surgical, but as a general principle, for patients with mild to moderate SUI, then only the non-surgical treatment will work. Most patients with the severe SUI will require surgical treatment. So, but it is worth trying while they are waiting for surgery. Lifestyle changes, that means weight reduction, because it is more common in obese patients. Then avoid tea, coffee, smoking, etc. And physical therapy in the form of Kegel's exercises by Arnold Kegel in 1948. Bladder training, I'll be doing detail. That means timed passage of urine. Say initially 2 hourly, then 2.5 hourly, then 3 hourly, like that. Drugs are limited drugs which work for SUI. We have got a lot of drugs for overactive bladder syndrome or urgent incontinence, but very few drugs for SUI. But definitely duloxetine 20 milligram OD, maximum 40 milligram OD can be tried for these patients. Devices, there have been many devices applied, but like QRS ring and etc., but they don't really work that well. Bladder drill and is more useful for, is like equivalent to bladder training, and more useful for urgent incontinence. And biofeedback helps actually in better Kegel exercise or physical therapy. So behavioral therapy is better than alpha agonist, neuromodulation and hormones, but more useful for urgent incontinence than stress incontinence. But all women with bothersome SUI should be offered non-surgical options first, and surgery is reserved for women who decline or fail non-surgical therapies or from moderate to severe incontinence. So what are the surgical options for SUI? Usually I'm talking now when the patient requires surgical treatment, right, moderate to severe SUI. So open Birch corpus suspension, and which is a modification of MMK operation. But these days nobody does MMK operation because of severe risk of osteitis pubis. So that is Birch corpus suspension we do often. It can be done by open route. It can be done by laparoscopic route. And the anti-repair was done in the past, anti-colporaphy, Kelly stitch, passage stitch, or but the success rate is poor for this procedure. Then suburethral or midurethral slings, including traditional suburethral slings and minimal invasive sling operation, can also be done. They are very good. Actually, we have had good experience of them, but unfortunately, because of US FDA warning and non-availability of them and lot of lawsuits in USA and UK, so they may not be available in many countries. And in India, though we still are getting some of them, but there's a real chance that they may not be available in future and they may be banned. So we have to find alternative to them, but otherwise they are a good method actually. And then needle suspension, Pereira, stem operation were popular about 20 years back, but now they have been superseded by other better methods. Peripheral injections are more useful for intensive splinter deficiency, and they are good, but the drawback is they are not easily available in India, collagen tissue, and they cost a lot actually, about 25 to 50,000 rupees, and every 6 months they have to use them. So how many patients can afford that in India? Artificial respiratory is a last resort, to be done when all other methods fail. So traditionally, we are doing either MMK operation or, this burst corpus suspension, and then slings, and including the modern slings we are doing. So at the level of recommendation is basically TBT or TOT, both have grade 1 recommendation, and facial, this corpus suspension also grade A, where laparoscopy is B, but others are D, and arterial respiratory has got pending. So sling surgery were used in the past, but because when the synthetic sling came, then they went into disrepute. But now, because of the a lot of controversy about use of artificial slings and mesh erosion issues and a lot of adverse publicity and the warning by US FDA. So the this TVT, TOT using artificial mesh are into disrepute, and there is a risk of them being banned, and they are not available in many countries like UK. So we are then they coming back of autologous slings like fascia lata, rectus fascia sling. So I'll mainly restrict my talk to autologous because these are the two which we have done as part of thesis. But heterologous like porcine, dermis, ox, dura, or synthetic nylon Gore-Tex, we no longer use them. So they mainly the fascia lata, rectus fascia, which I will be talking. So why autologous sling surgery? Because synthetic slings, though were useful, they were very good, but US FDA gave a warning about them in 2011, and safety of them and long-term complication, mass erosion exposure challenge. There have been malpractice litigation, and rate of mass erosion was higher after TOT and then retropelvic sling surgery. So there is renaissance of autologous slings in them. So they were, in 1910, Goebel from Germany, Eldreich from USA, and 1978, again, McGurry and Leighton used them. But after, they went into disrepute when the synthetic sling came, which was much easier to do. So, but now they have come back into this thing, and we have used them as thesis in our department, and we have published them also about them in European Journal of Obstetrics and Gynae. So, what we do, the rectus mesia fascial is obtained through suprapubic incision, and a fascia lata is obtained through lateral thigh. It can also be used. Okay. So, this is the basically in the initial evaluation of patient with SUI, we take history, taking physical examination, and then objective demonstration of SUI on examination, and post-visual urine and urine analysis. Urodynamic are not done for every single case, but if it is a mixed urinary incontinence, antical apical prolapse, symptoms suggest avoiding dysfunction, or post-residual urine is more, or previous failed in incontinence surgery, and history of radical pelvic surgery or radiation, or associated neurological disease. That means only in complicated patient. For straightforward SUI, we can do surgery without doing them also. So normally the autologous rectus fascia thing which we did, we put the patient in lithotomy position. We open the abdomen just like we do Purandesh FOGSI, and we take 8 into 1.5 to 2 centimeter rectus fascia. We cut it from the abdominal wall, and then the patient is put in lithotomy position, and then we give about 2 centimeter vertical incision. And this is the traditional pre-operative procedure we do, that ciprofloxacin or this thing we are doing it. So this incision is given, and 8 centimeter to 1.5 centimeter of rectus fascia is taken, and then it is put in a solution containing dexamethasone, heparin, and gentamicin solution. And then we put 2-stage suture at end of both the graft using number 1 Prolene suture. Dissection is done transabdominal in the space of ridges, just like for Birch corpus suspension. And then at the vaginal end, we give 2 centimeters in the mid-vaginal, just like for anti repair, or you can say for TOT or TVT, just below the urethra, and vaginal wall is dissected from underlying urethra till inferior pubic ramus on each side. Then a long Kelly's clamp is inserted through the abdominal incision in the space of ridges, and taking care that, holding bladder and urethra into left hand so that we don't injure them. And then the tip of this Kelly's clamp is visible at the vaginal end, and then we just give a stab at the tip of it so that we avoid injuring the bladder and urethra, and it comes through the vaginal route in the dissection area. And then someone from below feeds the sling with stitch on it, and then we pull it up in the abdominal this thing. So it becomes like TVT basically. And then so sling is anchored to the periurethral tissue using 2-0 vital suture, and then on abdominally we put a artery fossa underneath, and we tie it to the rectus sheath. So, and we do cystoscopy basically to rule out any bladder or urethral injury after this. And then it is just closed. So basically it is sheath made of rectus fascia sheath. It is tied to the, just like in TVT fashion, we tied to the anti-abdominal wall, to the anterior to the rectus sheath, but don't make it too tight. to avoid any avoiding this. So this is the pictures. Basically, we take it into 2 centimeter. You can see on the right side, and then this is how it's put. You can it's visible in the vagina at the vaginal end, and that's how we tie it to the anti-rectus sheath on that. Yeah. And this is what the picture will come ultimately. So side to the just like TVT, and usually 3 to 4 we keep the drain for a few days, and we leave the catheter for 72 hours. Now initially we were keeping it for 5 days, and then antibiotics are given for a few days, and then when we discharge the patient after 72 hours after removing the catheter, she is able to pass urine, and if PVR is less than 100 ml. Otherwise, sometimes we have to put the catheter again for a few more days. We required actually initially catheterization for some patient, urgency, UTI, wound hematoma, collection, surgical site infection. So in our initial 5 to 10 cases, the complication rate was higher, but as the technique was standardized more, the complication rate became lower. And then later on, it was only 6.7% retention rate, and surgical site infections about 6.7%, wound collection 6.7%. And this is what we basically published it in European Journal of FOGSI and Gynae, almost 100% success rate at 6 months. Operating time was about 55 minutes. And then we were asked to write a review editorial for Journal of Gynae India, and that it's coming back, autologous facial sling. And now we have started using fascia lata also. Only thing we need some our colleague from plastic surgery for it. In this case, fascia lata is harvested from thigh with the help of a stripper, and again about 18 to 1 to 1.5 centimeter of it is taken. And it is actually, in this case, you can see the stripper, and we are taking 10 centimeter, 8 to 10 centimeter long fascia lata, 1 centimeter wide. With that, this is how the fascia, and again we put 2 proline suture at the end of this thing, and then these are the needle. But same, it's a TOT. Basically, rectus fascia is like TVT, and this tensor fascia lata is like TOT. So the patient, very obese patient, past surgery on abdominal wall, bad adhesion, then we avoid going to the abdominal wall, so we can do in the TOT, and this is a much smaller and simpler operation then. So you can say we basically feed the, we put the TOT needle, and at the tip of the needle will come here, and then we put the sling, this tensor fascia lata with the nylon loop proline stitch attached to it. So it puts just like TOT basically. So in TOT, we are taking the synthetic mesh. In this case, we are basically putting into the eye of the needle and the TOT, and ultimately this tensor fascia lata will sit in the mid urethra level, just like in TOT, you can say. So ultimately, you can see on both ends through the obturator fossa membrane, this has come out, and you can see then RT forceps in the vaginal end, so that we don't make it too tight. And then we just cut those. We make a stitch at the end of these stitches, and we remove the nylon stitches or proline stitches. So it will sit in the mid urethra. So it's like TOT basically, but only thing is instead of using synthetic mesh, we have used the tensor fascia lata. It's a simpler and smaller operation, and then usually no need to do cystoscopy for it, but you can do just to make sure. But usually the chance of injuring bladder and urethra much lower in this case. And again, the post-op care is just like same, and as compared to it has got a smaller operation time as compared to the fascia rectal fascia sling. Smaller operation, and wound complications were also lower. So we are taking it. So ultimately, autologous fascia sling came in vague due to long-term mesh-related complications due to mid-urethral slings. Rectus fascia fascia lata are commonly used autologous facial. Traditional rectal fascia sling was recovered for complicated SUI in cases where synthetic mid-urethral slings are contraindicated. When applied, the mid-urethral level, it can be used for uncomplicated SUI also. And fascia lata carries relatively less complication compared to rectal fascia sling. So thank you very much.
Request Archana Jha madam, excellent presentation, sir. Archana Jha madam, can you unmute, madam?
With that, Hobi madam, namaskar.
Namaskar, it was an excellent talk, Dr.
Sir, short and crisp.
Thank you.
You ended right in the time. There
Yes,
are some queries in the chat.
For all of us.
Answer them.
Like place like Bihar, we have to do this surgery.
I congratulate all of you, madam, for organizing such a wonderful Urogynec seminar. Our postgraduate and fellows are with me here.
Dr. Sharma, whether you can answer Dr. Samir Pradhan's question?
Yes, ma'am.
Yeah, it is in the chat box.
Oh, okay. We'll just
please answer him there.
The question is, why not keep the center part of the rectus sheath intact and the strips of the rectus sheath tied to each other over a hemostat at mid-urethral region over a hemostat as was in the original acid sling.
Okay, we can do that also, madam. Basically, we have put a artery forceps at the mid-urethral region and अच्छा hemostat. अच्छा.
forceps पे नीचे टाइप करनी है.
Okay, yeah. We can do that, man. We can do that. Aim is to do not make it too tight because otherwise patient can have voiding dysfunction. So I fully agree with Dr. Samir Pradhan. Thank you, sir,
And
for
every time we need not do cystoscopy. That is what you were talking about.
For TVT, usually we do, madam. For this rectus fascia, it's better to do cystoscopy because it's going, through the bladder neck area. So there is a risk of perforation. So it's better to do. But for TOT, this tensor fascia lata, we don't have to do. In other words, the rectus fascia is like TVT and tensor fascia lata like TOT.
TOT. Yes. Nice
Thank you,
surgeries
sir.
and presentation, sir. Thank you.
Thank you, sir.
Thank
Now
you.
I request Archana Jha madam to introduce the next speaker, Amita Jain, to give her speech on complications of synthetic slings. Over to Archana Jha madam. Can ICOG team share the CV of Dr. Amita Jain?
Amitabh Jain, madam. Yeah. Dr. Amita Jain, ma'am.
Yes,
please go on.
Amita is traveling, I feel, but she's presenting herself. Thank you very much, Dr.
Senior
Amita.
consultant gynecologist of Medanta Urology and Robotic Surgery.
Hi,
and
Amita.
faculty in Department of Oxford.
Best of luck.
Southern
Amita is our star attraction, yeah.
International Advisory Board. And so we will speak on complications of synthetic sling.
Yeah, thank you, ma'am. Can I share my screen?
Yeah, sure, ma'am. You're most welcome.
So all of you can see my presentation?
Yes, we can see. But need to, full screen, fine.
So I'm going to talk on the complications of synthetic sling, and I think Professor Sharma has already mentioned the thing that why we are apprehensive of using these slings. So I have no disclosures. So if we talk about use of synthetic slings, we all know that it is used for the correction of the hypermobility of urethra to stop stress urinary incontinence. And how does it work? It's do a dynamic kinking of the urethra during stress, and you can see that either it will reinforce the pubourethral ligament or it will reinforce the suburethral vaginal hammock like it is done in Birch-Corpus suspension. And in this way, it is preventing the hypermobility of bladder neck from opening the mid-urethra. And we all know that the synthetic sling was first introduced by Petros in 1996, retropubic root, and later on the obturator, which was done in both the way, outside in and inside out, was introduced. And we also know that we are having a very, very good long-term data of these synthetic slings. Recently, this is a publication which is showing a 20-year long data with a very good sustainable cure rate. So, we know that the success rate is proven, but it's still because of complications, we are finding ourselves, in a dilemma whether we should use or not. So if we talk about the complication, I have written SUI procedures. That's mean any procedure which is causing correction of stress incontinence or urethral surgery can cause these complications, whether it is perioperative or delayed. What makes the difference? Presence of mesh. And as Dr. Sharma mentioned that in 2011, FDA issued this warning. And after that, you can see there is a gradual decline in the use of mid-urethral synthetic sling. And on top of it, you can, whenever you are Googling the synthetic sling, you will find these kinds of, advertisement where lawyers, they are money by putting, heavy lawsuits on the companies as well as the doctors operating, especially in abroad. And that's the result. It is written in Campbell that as synthetic mesh use becomes more restricted because of all these things, there may be a chance in practice towards autologous sling material or colpo suspension. It has been accepted in guidelines as well, but see the fact. Yes, there is a decline in the use of MUS, but we are still not able to use the colpo suspension or autologous sling. And what could be the reason? Lack of training. So that's very
Dr. Amita, you are not audible. Dr. Amita, net connection is got cut. Dr. Amita.
Dr. Amita?
Dr. Amita?
Your screen share is lost, and as you are traveling, we are not able to listen to you. You have to unmute. Please unmute yourself.
okay. I think in between there was some loss of, So now you can see the thing. You can see.
We are able to see you, but in between, no, as you are traveling, your net there is a net issue. If you can take your vehicle somewhere sideways, and if you can complete your talk.
Are you able to listen? Are you able to hear me or not?
Yeah, we are able to listen to you, but in between it is lost, and your screen share is also not seen properly.
Yes, ma'am. It was lost. I don't know something happened.
Okay. Continue.
So, are you able to see any slide or not till now?
Now we are able to see you. Last two slides we have not seen, but it's okay. You can continue from this slide.
Okay. Okay. Just a minute. So I was coming to the mesh erosions. So mesh erosions, it could be either palpable through the separated mucosa. That's mean that there was an incision line, and through that, or there was a initial injury, through that mesh is getting exposed. Another thing is extrusion. That's mean it is actually piercing through all the mucosa, all the vaginal wall or mucosa of the hollow organ to, visible inside the organ or at the vagina. So actually true extrusion and perforation are very, very rare. It should be like a very thinned out vaginal mucosa or something. Otherwise, usually it is the exposure. Once the incision line is not very nicely taken care of, or stitches got torn, or you have actually not seen in cystoscopy that mesh is inside. So you can see that is the rate of retropubic and transobturator in vagina, bladder, urethra, and bowel. And you can see urethral bowel is very, very rare. and it is with the transobturator that the vaginal wall exposure is greater. Obturator, you can see in this way, the fornical perforation can be seen, and it should be actually so that you can actually remove and reinsert it at the same time. So that's a very important thing. Apart from that, adequate hydrodissection, that's keeping the vaginal wall thickness very good. And also, whenever you are putting it again, you should do it with a deeper plane. So these are very important thing, and closure should be done with a delayed absorbable suture. Now coming to the if you are not able to detect, then probably patient will present with hysperunia. The husband will say that there is some pricking sensation, there would be vaginal discharge, pain, bleeding. So again, if postmenopausal lady with very thinned out vagina is there, estrogen than 1 centimeter, then probably you can see that with some estrogen, sometimes estronization of the exposed part occur. But if it is not and patient is suffering, then you have to do a kind of all the mesh you have to remove, and the closure should be always tension free. So you have to actually take out the whole of the surrounding vaginal mucosa. You have to separate it out and mobilize and then do the closure. Now urinary tract use bladder catheter or see, this is the video for this being used when the previous surgeries LSCS is done, bladder is quite adherent. Then sometimes you are getting your needle again inside the bladder, then it's better to use these things. And you can see all of the precautions, like the plane of the TVT needle should be that it should be towards the mid labia majora, towards ipsilateral shoulder. But things are very important to avoid bladder injuries. But if at all it occurs, then what you have to do, you have to do an intraoperative cystoscopy with 70-degree or 30-degree lens, and you can recognize, withdraw, and you can replace. So, this is the whole, and need to catheterize for a prolonged time. It will heal in 2 or 3 days time, and you can reinsert the same. Or if there is a urethral, to recognize it with a 0-degree lens, therefore you can see that it was a patient which actually got operated, and everything was all right. But at the time of discharge, she called me that doctor, there is a lot of discharge from the suprapubic wound. And once we did the drain fluid the creatinine, then it was high. So it was urine. It was coming to the suprapubic wound. So you can see that the cystoscopy is so important that you have to see each and every vagina, mucosal fold should be unfolded. Otherwise, a very small mesh can cause. This was a kind of effect that from that bladder through suction, the urine was coming out from the suprapubic wound. And patient is doing well after 5 years of the surgery. So you can see it was like very small fold, very small. Kind of UTI symptoms. So whenever patient is having UTI symptoms,
Madam, you are not audible.
Hello?
Yes.
Can you hear me?
Yes, ma'am.
Okay. So you can see if there is no stone formation on that, then you can actually remove it by scissors, and then probably by a forceps you can take it out. It will be easier through urethral opening only. But if suppose the stone formation is there over that, then probably you are in mess. You have to use a laser And this is the, laser has been used 1.6 joule to 30 hertz was the, energy which was used. And you can see the stone was in piecemeal and this was the part of mesh. And then we repeated the cystoscopy after 3 months, and you can see the mucosa was completely healed. The beauty was that we have not removed the part which was extravesical. So still patient is continent because of the fibrosis. It is taking care of the urethral support. So that's the difference. Otherwise, you have to get it removed completely and patient will be incontinent again. That it's the synthetic sling is culprit. You can see even with the autologous sling, you have to use a thread. And if the thread is coming through the hello, can you hear me?
Yeah, yes.
Okay. So, but
Yeah, you're audible, Amita.
if
You're
it
audible.
is urethral injury, I'm extremely sorry, ma'am. Can you hear me? Or
Yes,
I should do my talk? Yeah. So I think I'm just finishing it. The unite tract injury, urethral one, you have to actually you don't need to proceed, and also catheter should be kept for 2 weeks because there are very very high chance of uretherovaginal fistula and incontinence. This is the joint position statement, and you can see that already I have discussed all the things, paper which is published in ICOG, and it is very clearly showing that if, the vaginal perforation is very small, then only you can do observation or kind of conservative management. Otherwise, sometimes partial complete vaginal excision would be required. And visceral perforation, again, the endoscopic partial excision can be done. But if recurrent exposure is there, then probably you have to excise the complete thing. Again, it is about the, the growing pain. Now talking about the pain part, it was not exposure, but only pain. Patient is complaining pain. So you can see that usually it is done by doing some kind of conservative management. But if it is persisting and, extravaginal pains are there, then with obturator mesh, growing pain are usually seen. Then you have to remove that partial part of the mesh, and it is not very easy. I'm telling you, it could be a lot of morbidity.
Sorry to interrupt you, ma'am. Your time is up.
Okay, I'm just finishing. The half of the time actually I was struggling. So you can just see that to avoid this thing, growing pain, please keep it as medial as possible. Don't follow these kinds of landmarks. You just need to go just below the adductor longus tendon and at the superior medial angle. In this way, you can avoid the adductor longus tendon. And that's why it is said that though there are 2 approaches of the obturator one, the outside in is actually having less chances of growing pain, because inside out you are going more laterally. So you can see the vascular injuries, nerve injuries, how, you can avoid the things by cadaveric dissection. It has been seen that you have to follow the same trajectory. Like you can see, just see this small video, that how to see the landmarks, how to palpate the adductor longus tendon, and then, below this is the superior medial angle, and you can put one finger inside, and you can actually the thumb and the finger meet at the superior medial angle as in this way. Okay. So the trajectory should be always same, whether it is inside out or outside in. And otherwise, you can see the surgery, if for the growing pain has to be done, it will involve with a lot of many of the muscles has to be cut to remove the part of the mesh. And vascular injury, I'm just finishing that major vessels are actually quite lateral. You can see, so you have to actually try very hard to do these kinds of vascular injury. Usually inferior epigastric artery is injured. So for that, just keep this TVT needle at the distance, within the distance of 2 centimeters from the middle. So it will avoid the things. If vascular injury occur, if it is venous, it will form hematoma, usually conservatively managed. But if it got infected, you will be in mess. But arterial beat, I got one complication, and believe me, that patient was actually was going to collapse because of lot of collaterals. I was not able to actually got that bleeder. It got it into spasm, and I have to take the help of interventional radiologist. So you have to be very, very careful about these kinds of complications. Voiding dysfunction, if it is at all, it is there. Probably that's the thing, that if it is preoperative, get a urodynamic done to confirm the cause of the voiding dysfunction. Avoid surgeries in these patients. Even I was the part of USI guidelines. It was stating the same thing. And if at all it occurs, probably you should avoid bottom-up approach. It should be, bottom-up approach is the better than top-to-bottom approach. And if it at all occurs, you have to actually cut the middle part of the sling. And if it is done after 3 weeks, again, it will not cause incontinence, because the fibrosis of the left out part will take care of the continence. As you can see in this patient, it was having high pressure on urodynamics. That was the sign of obstruction. So that's the end. You just should use these kinds of, terminology and classification. You should report your complications. And between the regrets of yesterday and dreams of tomorrow, there lies the opportunity of today. So I still think that the synthetic slings can be used if you are taking care of the complication. Thank you so much. You can ask any question if you want. Hello.
Yeah, it was really excellent presentation. As you are traveling and you have taken a lot of pen to present this, congratulations. It was very informative and very practical tips you have given us. Thank you very much. And thank you, ICOG team, Dr. Subhan and Dr. Kavita, for giving me this opportunity to share important session and so learned speakers. Thank you so much. It was very good. Thank you so much.
Thank you, madam, for giving me the.
Thank you, Dr. Amita.
Really sorry.
And in spite you are traveling, you did justice to your talk. And I don't think there are any questions in the chat box. Might be there. You can put your email ID in the chat box. They can send the queries to you through an email.
Hello.
Dr. Meena, we'll start the next session. We are
Yes,
live.
yes, madam. Yes, madam. Thank you, madam. So, thank you, Dr. Amita, madam, and the chairpersons of the second session. Now, I would like to introduce Rekha, madam, Leena, madam, Bharti, madam, Rekha, madam, ICOG fellow, President-elect IMA Bhagalpur, and past President Bhagalpur Obstetrics and Gynecology Society. Next slide. Dr. Leena Nair, Vice President Bhagalpur OG Society, Secretary Bhagalpur Menopause Society, and many more applause to madam. Next. Professor Bharati Mageshwari, Professor and Head of Department, IVF Muzaffer Nagar, Chairperson FOGSI MTP Committee, Fellow ICOG AFOG, to take over the session and introduce the speakers of the next session. I'd like to ask the chairperson to introduce the speaker of the next session, Karishma Tarian. Go to the chairperson.
Good evening. Good evening, everyone. Can you hear me? Dr. Bharti Maheshwari here. Hello?
Yes, yes.
Yeah,
We can hear you.
Yes, yes. So first of all, congratulations to all organizers for this wonderful ICOG workshop or certificate course. And as we all know that in the next session, that is on a very important topic. And I have to introduce this speaker, Dr. Karishma. And we all know that she is a present consultant at the Center for Urogynecology and Pelvic Health. And she has a lots of contributions in this field. And we are having her talk on the important topic. And I think that is the recurrent UTI, Dr. Karishma.
Yes.
Yeah, so recurrent UTI is a very common problem, but of course has a very though it seems very easy, but it is very difficult to manage. So we are eager to know what are the important issues we can handle regarding recurrent UTI, and how we can prevent, how we can manage this recurrent UTI. So now to our speaker, Dr. Karishma.
Thank you so much, ma'am, for the introduction, and thank you to all the organizers for the opportunity to be present at this forum where such stalwarts are giving their talks. So, like ma'am just said, that recurrent UTI is a very, very important topic, and we all, as gynecologists and urogynecologists, come across patients suffering from recurrent urinary tract infections. So, let's just start. We all know urinary tract infections are the commonest infections to happen in women. It's infection of the urinary tract causing an inflammatory response. UTIs are more prevalent in women as compared to men, 20 times more. At least 50% of women will suffer from one UTI.
Your slides are not seen.
My slides are not
Slides are not seen, yeah.
No. We can't see your slides.
Okay, I'll share again. I'm sorry. I could see just a second. Is it visible now?
Yeah, it's visible.
Yeah. So where I was just talking about urinary tract infections in women, and they are more common in women as compared to men. At least 50% of women will at least suffer from one UTI in their lifetime. 11% will have at least one infection a year. 20 to 30% who had one episode will have recurrent UTIs. And the prevalence keeps on increasing with age. So it is an extremely prevalent condition. Before we move forward in this talk, it is important to understand some terminologies and definitions. What is acute bacterial cystitis? We know urinary tract is divided into upper and lower urinary tract. So any culture-proven infection of the bladder with a bacterial pathogen which is associated with acute onset symptoms, such as dysuria, with urgency, frequency, hematuria, etc., is characterized as an acute bacterial cystitis. Now, this urinary tract infection can be of two types, uncomplicated or complicated. Uncomplicated infection is infection that occurs in a woman with normal anatomical urinary tract. Complicated infections occur in women who have anatomic or functional abnormality of the urinary tract or women who are immunocompromised. For the purpose of today's lecture, we'll be discussing recurrent urinary tract infections in healthy women with no anatomic or functional abnormality of the lower urinary tract. These patients are often referred to as index patients. So how to manage uncomplicated recurrent urinary tract in an index patient? Other important definitions are asymptomatic bacteriuria. Asymptomatic bacteriuria is when the culture keeps coming positive, but your patient has absolutely no symptoms. Therefore, asymptomatic bacteriuria. Such asymptomatic bacteriuria cases do not require treatment other than if they are pregnant. Coming to recurrent UTI, I was just going through the chat box and there was a lot of confusion about the definition of recurrent UTI. So it is defined as 2 uncomplicated UTIs in 6 months or 3 culture-proven UTIs in a year. It does not include asymptomatic bacteriuria. And like we said, 25 to 30% of patients who have one UTI will end up having recurrent UTI. Recurrent UTI is divided into 2 types, persistent bacterial infection and bacterial reinfection. It is very important to be able to differentiate between the two. Bacterial persistence is that a lady came to you with UTI, culture-proven UTI, you gave her antibiotics, she got better. But again, in less than 2 weeks' time, she again developed symptoms. That is persistence. Bacterial reinfection is when there was a culture-proven infection, you treated the infection, and the next infection happened after a period of 2 weeks. It is important to differentiate between the two because reinfections indicate increased host susceptibility, whereas bacterial persistence is more common if there's an underlying anatomic or functional pathology. Now, pathophysiology, we all know that there is a reservoir in the gut, in the vagina. The bacteria climb up through an ascending route through the urethra. They enter the bladder, attach to the urothelium, cause an inflammatory cystitis. The most common bacteria is E. coli. We know 80% of the infections in women are caused by E. coli. Others are Staphylococcus saprophyticus, Klebsiella, Proteus, and Enterococcus fecalis. Most of these bacteria are gut pathogens. In premenopausal women, the risk factors which increase the chances of recurrent UTI are increased frequency of intercourse. Having a frequency of more than 5 times a week is associated with a 30% chance of recurrent UTI. Use of spermicides, frequent new sexual partners, dysfunctional voiding patterns, UTI in childhood, and family history of UTI are other risk factors in younger women. Postmenopausal, perimenopausal women, we know because of the change in the vaginal flora, change in the vaginal pH causes a reduction in the lactobacilli, which facilitates the climbing up of E. coli. So this itself is a risk factor, that is the perimenopausal, postmenopausal age group. On the top of that, if your patient has incontinence, prolapse, high residual volume, or history of UTIs when she was younger, that increases her chances of postmenopausal UTI. Now, classically, when a patient comes to you with acute episode, she will present to you with symptoms of dysuria. It has a 90% accuracy for UTI in young. Urinary urgency, frequency, pain, hematuria, or new or worsening incontinence. Be very careful in older women. They may not often present with dysuria alone. Imagine you have a patient with overactive bladder. You're treating her with drugs. She's well controlled. Suddenly she comes to you saying, doctor, there's an increase in leakage, or there's an increase in frequency. Even such atypical symptoms in elderly women may be a symptom of UTI. Whenever such patients come to you, always take a detailed urogynecological history, that is symptoms of UTI, how many UTIs she's had, what treatments does she take, does she get culture done for those tests, those episodes, does she have other lower urinary tract symptoms like on the good days, like does she have incontinence, any signs and symptoms of prolapse, what antibiotics she has been on, and any past medical history of diabetes, neurological disease, previous surgeries, etc. Any history of vaginal discharge. Also, in cases of recurrent UTI, it is very important to ask the patient about interim period. That is the period between one infection and the other infection. Is the patient 100% all right, or does she have some lower urinary tract symptoms at that time also? This is worth evaluating because such patients may have overlapping overactive bladder or bladder pain syndrome along with UTI. Is the UTI triggered with sexual intercourse? What is the relationship with hormones? Does she get it during her periods? Is she menopausal? Is she on any kind of HRT? So this detailed history is very important in women who present with recurrent infections. Examination, a very thorough pelvic examination. We know the details of it. Look at the urogenital anatomy. Look at any periurethral swellings like diverticulum, which are often missed. Estrogenization of the vaginal tissues, vulvovaginal atrophy is a common risk factor for recurrent UTI, pelvic organ prolapse, and do a basic scan for post-void residual if you're suspecting anything abnormal with her voiding. If the patient is young and she's come to you with with typical symptoms and it's a first UTI, you may not always get a urine routine and culture done. In such cases, just a dipstick will do and you can start the patient on empirical treatment. But in cases where there are atypical symptoms and in recurrent infections, urine routine and culture form the mainstay of diagnosis. Now coming to urine routine and culture. Collecting the urine sample in women is a challenge. You have to teach them about how to take the midstream clean catch sample because high chance of vaginal contamination is there. Because the urethral opening is between the lips. So you will have to teach your patients how to collect the right sample. If your patient is wheelchair bound, or she has difficulty in bending, or she is very obese, and she's coming with samples which may look contaminated to you. In such cases, there is no harm in taking a catheterized sample in your clinic under aseptic precautions. Now, when we analyze a report of urine routine, there are certain factors which hint towards an infection. For example, presence of pyuria. It's often confusing what is suggestive of infection, 2-3 pus cells or more than 5 pus cells. So you should know how the sample has been processed. If it's a spun sample, then even more than 2 pus cells are significant. In an unspun or uncentrifuged sample, 10 pus cells per hyper field are sensitive. Hematuria, presence of anything more than 3 to 5 RBCs is significant. Presence of nitrites is very, very specific for an E. coli infection. But if the patient is suffering from, say, a staphylococcal infection, then nitrites may be negative. Now, urine culture. We know that the culture sample should be taken and processed within 2 hours. The colony count is said to be 10 to the power 5. This is something which is being followed for the last 60 years. But now, according to the recent guidelines, counts as low as 10 to power 2 in symptomatic women are also considered as significant. There are a lot of new molecular diagnostic tests which are coming up, but currently they cannot be recommended because now the notion that all individuals are bacteriuric is there, that there are some bacteria which are normally present in the bladder. Bladder is not a sterile environment. And these bacteria which are not causing symptoms may actually be protective against bad bacteria which cause recurrent infection. Cystoscopy is not needed in all cases, only when you're suspecting a urological pathology. Now, before we go to treatment, a little word about antibiotic stewardship. It's very important, especially in recurrent UTI. We give long courses of antibiotics. Most guidelines say that short duration, not exceeding for more than 7 days, should be followed for most women based on the culture report. Start with first-line antibiotics always. Now, this is a table which shows the first-line antibiotics, which is nitrofurantoin, trimethoprim, sulfamethoxazole, and fosfomycin. Dose for nitrofurantoin is 100 BD for 5 days, may be extended to 7 days. Trimethoprim, sulfamethoxazole BD for 3 days, may be extended to 5 days. Fosfomycin 3 grams single dose. Test of cure is currently not recommended. Symptomatic relief is sufficient. Repeat urine cultures may only be done if you started the antibiotic empirically and the patient again developed symptoms. Prevention, the second part of recurrent UTI is first is treating the acute infection, second is prevention, divided into non-pharmacological, estrogen, antimicrobial prophylaxis, and immunoactive prophylaxis. Non-pharmacological methods we already know, like lifestyle modifications, drinking water, plenty of water. Don't ask the patient to drink 10 liters. Anything more between 1.5 to 2.5 liters is all right. No patient should be drinking less than 1.5 liters, not holding urine, voiding after intercourse, cleaning from front to back, etc. Other techniques which may be helpful and can be recommended to the patients. A local estrogen has a huge role in preventing recurrent UTI, especially in perimenopausal and menopausal women, and hence should be recommended. Pharmacological methods are prophylaxis. That is, women who have recurrent infection sometimes can be put on prophylaxis. These are of 3 types: low continuous, self-culture and treatment, and post-coital. Low continuous is when you keep the patient on a low dose of antibiotic for, say, a period of 3 to 6 months. The antibiotics used are here: fosfomycin, Niftran 50 or 100, trimethoprim, sulfamethoxazole, and cefalexin. They all have good up to 95% reduction rates, but the adverse effects because of long-term antibiotics should be told to the patient. And the patient should be told that once after stopping the prophylaxis, the recurrent UTI can come back. Next is self-start. That is, it can be done with compliant patients. That a patient, when she feels she has a UTI, she takes a 3-day course. If she responds, great. If she doesn't respond, then she informs the clinician. Third is the post-coital prophylaxis in women who have a temporal association of UTI with intercourse. It is very effective, especially in these women who have a coital relationship. And these are the antibiotics which can be used for post-coital. The only condition is that you have to give it within 1 hour of intercourse. Non-antibiotic strategies like cranberry extract, acidification of urine, D-mannose, etc. cannot be recommended as there is very little evidence. Although methenamine, which is currently not available in India, is a bacteriostatic agent for urine. And it has shown some evidence in reducing the chances of UTI. It's available in UK and US. Lactobacillus suppositories, again, do not have much evidence. This is just a summary of whatever I've spoken. This is as per the latest 2024 AUA guideline. It's freely available on internet. And in the end, I just want to conclude that women of all ages can suffer from recurrent UTI. One should look for predisposing factors. The predisposing factors are rare, but can be considered if nothing is working. Start with behavioral changes, antimicrobial analysis, and in the end, give antibiotic. I'm done. Thank you. If anybody has any questions, I'll be happy to take it.
Excellent presentation, Karishma. You've dealt with all aspects of recurrent UTI. It is a very, very annoying problem for the patient as well as the clinician. and you've dealt with every aspect of it very beautifully. So congratulations.
Thank you, sir.
We'll take the questions in the chat box.
Certainly, ma'am, I'll answer it.
So can we move ahead to the next session?
Yes.
Next talk.
Yes, madam. Yes, madam.
Can we have the CV of Dr. Ramani Devi? Actually, Dr. Ramani Devi needs no introduction. She's known to all of us. She's a legendary figure in FOGSI and very popularly known as the endometriosis lady of India for her extensive research and work on endometriosis. She's currently the president of Tamil Nadu Federation of Obs and Gynae, National Vice President FOGSI 2020, International Advisory Board member of Fertility Society of Bangladesh, and also ICOG Governing Council member from 2018 to 20. She has won numerous awards and accolades and has published many articles and books especially on endometriosis. So, madam, we are very eager to hear you speak on a very important, again, an important topic for all of the obstetrician, that is OASI.
Thank you, Dr. Leena Nair, for your kind introduction. And let me thank the ICOG team for having be a part of this certificate course. And today I'll be giving my talk on OSE. That is one of the very common entities what we come across. Are you able to see my screen?
Yes, ma'am.
Yes.
Okay.
Okay. See, the obstetric anal sphincter injuries are always, it's a tug of war, whether it has to be dealt by the gynecologist or by the colorectal surgeons. But I think finally in the war, it will be the gynecologist who will be winning the task. So obstetric anal sphincter injury includes both third degree and fourth degree perineal tears. The overall risk of this injury is 1% of all vaginal deliveries. The condition may also be present in women without obvious anal sphincter tears during labor or delivery, and it is usually an occult type of injury. When you look into the statistics of UK, the singleton terms cephalic vaginal, first-time vaginal births, that is the primiparas, it has tripled incidence from 1.8 to 5.9 from 2000 to 2012. And the overall incidence in UK is 2.9, and 6.1% is primipara and 1.7% are multipara. An increasing incidence of third degree and perineal tear does not really indicate a poor quality care, but it rather indicates that the gynecologists or the midwives are able to pick up the defect at the earliest stage. Then you have to know the applied anatomy before going into OSE. The anal canal is about 3.5 centimeters and it is formed of the external anal sphincter and the internal anal sphincter. And the external anal sphincter is always, it is being divided into three types of muscles, subcutaneous, superficial, and the deep region. And they are involuntary muscles and they are being innervated by the pudendal nerve. But whereas the internal anal sphincter is a continuation of the circular smooth muscle of the bowel and it is under autonomic control, and 70% of the resting pressure, it is being contributed by the internal anal sphincter. Then coming to anorectal mucosa, the lining of the anal canal, it varies along the length due to the embryological derivation. The proximal anal canal is lined by the columnar epithelium and the distal one is lined by the modified squamous epithelium. Incontinence is related to internal anal sphincter injury compared to external anal sphincter injury. And the problems, the poorer outcome with respect to the development of defecatory symptoms and anal monometry results are very commonly seen in defect of this IAS, internal anal sphincter. The anal incontinence is defined as the complaint of involuntary loss of fecus, flatus, and or the urge incontinence that is advertently and affecting the quality of women. About 40% of the women with third degree and the fourth degree perineal tears during childbirth suffer from anal incontinence. So according to the classification of Abdul Sultan in 1999, the first degree perineal injury is only the perineal skin is involved in the vagina. And in the second degree, it involves few part of the perineal body. And in the third degree, it involves the external anal sphincter, or it can involve the internal anal sphincter. Among the external anal sphincter, it is again divided into 3A, B, and C, where A is about less than 50% of the thickness of external anal sphincter, and 3B is more than 50%, and C is both external and the internal anal sphincter are torn. And in the fourth degree perineal tear, injury involving the anal sphincter complex and the anal epithelium. So apart from this, we have what is called as a buttonhole tear. There won't be any damage to that of the perineal body here, but you can see a buttonhole tear when you do the rectal examination. So it is, if it is not recognized and repaired at an earlier time, it can lead to rectovaginal fistula. So these are some of the risk factors for OSC, that is macrosomia, nulliparity, Asian ethnicity, advanced maternal age, prolonged second stage, shoulder dystocia, occipital-posterior position, instrumental delivery, midline episiotomy, induction of labor, and epidural analgesia are some of the common risk factors. Whether it can be prevented by episiotomy, that's a burning question, because now the concept is you don't give routine episiotomy to every patient who's in labor. But instead, when you look into it, the protective effect of episiotomy is really conflicting. Mediolateral episiotomy should be considered in the instrumental deliveries, and the angle of episiotomy should be 60 degrees from the midline, in contrast to what we have been taught as 45 degrees. Perineal support should be done during crowning, and it seemed to be protective. Bond compression during the second stage of labor reduces the obstetric anal sphincter injury. So what should be the angle of episiotomy? This, according to the NICE guideline, they have proved that 60 degrees going to be very important rather than 45 or 40 degrees, because when the patient is having a head in the perineum, when you are going to give a 45 degree episiotomy, then at the end, after the delivery is over, it will be only 20 degree. But whereas when you give a episiotomy towards the 60 degree angulation, then definitely we can avoid anal sphincter injuries, and special scissors have to be used for them. Now, how we are going to prevent the OSCs? That is left hand slowing down. So the principle is you must deliver the head in between the contraction, giving a pressure at the fundus. At the same time, you give with the right hand, support the perineum, or you can even ask the assistant to support the perineum. This is the standard care to prevent the OSC. So these are all the pictures. So in a recombinant position, it can be in between the contraction, mild flexion to the head when it is coming out, and then perineal support, or this is in the lateral position, or this is in the all four position. Then again, when you are going to give Ventouse, also preferably the support, when it is given by a second assistant, it will be better and comfortable. And similarly in forceps also, you have to have a good perineal support. So this is again with the introduction of how can we predict and prevent OSC. So with the introduction of the endo-anal ultrasonogram, the abnormalities of anal sphincter anatomy has been picked up in 36% of the women after vaginal delivery in prospective studies. A lower risk of third degree tear is associated with a wider angle of episiotomy. Then how can we identify OSCs? A woman who delivers vaginally, we have to clinically assess what is the genital tract trauma if we have not given episiotomy, or when the patient has been given effective episiotomy, we have to identify whether there is any extension of the episiotomy or whether it is intact. Suppose if you find any abnormality, then it is our, we have to explain to the woman what we are going to do and offer her a comfortable analgesia and a good lighting and a position that is comfortable for so that the genital structures can be seen clearly. Systematic examination, including digital rectal examination to assess the severity of the damage, should be done. Then there are certain diagnostic tools for the assessment of OSC. They are traditionally, this is endo-anal ultrasonogram, anorectal manometry, and MRI. So all this have a sufficiently good amount of sensitivity and accuracy, but reproducibility and non-operative dependence and intraoperative use is possible with the endo-anal ultrasonogram, and anorectal manometry, it is not possible, and MRI definitely it is not possible, but MRI has got a better sensitivity, accuracy, and reproducibility and non-operative dependent. But experimental things are transperineal ultrasound and impedance spectrometry are some of the experimental tools for assessing obstetric anal injury. So here is an endoanal ultrasonogram where you can see this is the internal sphincter where you have from 9 to 3 o'clock position it is broken. And here again you can see the external anal sphincter, which is again, it is deficient in the almost from 10 or 11 o'clock position up to the 3 o'clock position. So how do your next question is having identified, how should you repair it? First is you wait till the placenta is removed and if there might be slightly excessive bleeding, give a firm application, and first degree tear generally that doesn't need suturing unless it is bleeding, but probably the second degree tears need suturing of the vaginal and the perineal muscles. So the suturing is in the midline episiotomy. Probably if you're going to give a midline episiotomy or the midline injury, it has to be sutured with a continuous, first vaginal mucosa has to be sutured. Then again the perineal muscles have to be approximated. Then you should come to the skin. See, according to the RCOG, everything is done in a single thing. Using a vehicle, either 2-0, you can start from the vaginal mucosa, then you can approximate the perineal muscles, and then the skin is close to that of the subcuticular suture. So that gives a very comfortable one with a minimal pain, and there are no knots in that. Then the fourth and the third and the fourth degree perineal tears, it is always safe to do it in the OT with a good lighting under aseptic condition, and the patient should have a good relaxation and analgesia, and so that the unless we have a good relaxation, the retracted torn ends of the sphincter cannot be identified. So this is the picture where you can see this anal mucosa being lacerated, perineum, everything. And then here it is a closure of the rectal mucosa that is followed by the closure of the internal anal sphincter. That is the continuation of that fascia, and that can be done using an interrupted suture. Then again, you have to repair the superficial transverse perineal muscles or the external anal sphincter, and finally you have to close the skin. So when you are closing the external anal sphincter, that we have to identify the levator part of the superficial levator part of the external anal sphincter, and it has to be approximated. How will you approximate? It can be either a side-to-side approximation or a overlapping type of approximation. Which is better? They have found in an RCT of 64 patients with a 1-year follow-up, they have found out that fetal incontinence is very low in overlap technique, and fecal urgency is also lower. But whereas dyspareunia, quality of life, and perineal, these two are equal in both, but whereas perineal pain is higher in end-to-end anastomosis. So ideally speaking, overlapping of the external anal sphincter gives a better outcome. Then who should do the procedure? Any obstetrician who is appropriately trained in managing this OSCs can do the do this procedure. And what are the suture materials that has to be used? Either you use for the anorectal mucosa, you use a 3O vicryl, and for the internal anal sphincter, it is better to use a PDS or a vicryl. And again, the surgical knot should be beneath the superficial perineal muscle so that it is not poking outside. And these are all some of the checklists where it should be done, what should be the preoperative preparation, instruments needed, and what are the postoperative care. So the postoperative care is very, very essential because there can be, if the stools are becoming very hard, there may be disruption of the suture line. And so we have to give lactulose and maintain the stool softener should be given. Again, it should not be combined with isopkel, and only lactulose is sufficient, and physiotherapy could be beneficial. And when you're the ideal to send the patient after she has passed the motion, and analgesic should be given adequately. It can be combined with lignocaine, and or NSAID tablets can also be given, and preferably avoid intercourse for a period of 6 to 8 weeks. And proper antibiotic prophylaxis should be given, as it will definitely, as it is needed, and it will prevent the infection part of it. And the patient should be followed up in the perineal clinic. And future deliveries, we have to discuss with the patient. Once a perineal injury OSC, whether we are near whether the subsequent deliveries, whether it has to be through C-section or whether you can go about with a vaginal delivery, we have to clearly discuss with the patient. And the role of prophylactic episiotomy in subsequent pregnancy is really not known, and it should be given only if it is clinically indicated. So when we are discussing with the patient, when the patient offers future delivery by LSCS, or if she has got an abnormal endoanal ultrasonogram, they should have an elective cesarean section will be ideal. So the point of future research is you should detect and try to identify the residual sphincter defects immediately after the primary surgical repair. And if they need a second surgery, it should be evaluated thoroughly, and it should be done by a senior consultant. And what about the prognosis? Following endoanal sphincter repair, 60 to 80% of asymptomatic at the end of 12 months. Most women who remain symptomatic describe the continence of flatus or fecal injury. So what should be the audit for OSC? Collected data should be regularly audited against recommended or local agreed standards. 100% evidence of adequate documentation of systematic examination of the vagina, perineum, and rectum prior to suturing, type of anesthesia, suture material, and post-operative advice, and doctors and midwives undertaking the part of OSC should attain regular periodic training courses. So medical legal issues, they are steadily increasing, and the litigation is related to failure to identify the injury. So always when we identify the injury and we discuss with the discuss and counsel with the patient and have a proper repair, I think we are safe. But poor technique, poor material, poor healing, poor counseling will always lead us to face the medical legal problems. So the good practice recommendation is avoid OSCs by preventing so that it will prevent anal incontinence. Any form of instrumental delivery, there is always an increased risk, and we got to give prophylactic episiotomy. Routine episiotomy is not indicated. Episiotomy use should be restricted to situations where it directly facilitates an urgent delivery. Then mediolateral incision is preferable instead of midline, and it should be 60 degree. And internal and external anal sphincter should be separately repaired if it is torn, and injuries to the
sorry to interrupt you, ma'am.
Yeah, it is the last slide. Rectal mucosa, they have a worse prognosis. So in women with the high risk factors, we have to always follow them properly. So the bottom line is, whether it is the surgeon, colorectal surgeon, or the gynecologist, it should be done in a perfect way. So this is a small video recording, but due to the sparsity of the time, I am not showing it. So thank you for the opportunity given to me. Thank you.
Thank you so much, madam, for that excellent presentation, giving a comprehensive view on the OSS and how to recognize it, how to deal with it, and how to prevent it, and also how to follow up the patients later on. So thank you so much, madam. I think all the delegates must have benefited from your talk. Can we move ahead for the next?
Excellent talk, and I just wanted to say that some of the queries are there in the chat box. Please answer in the chat box. Because of the shortage of time, we cannot take them. So thank you very much again. So we can.
Thank you, Vidya.
Yeah, we move ahead for the next talk.
So now we are in the last phase of this ICOG certification course. It has been a very excellent case for all the 3 days I have attended, and I think most of the people who have attended must have gained a lot from this ICOG certification course, because it was very beautifully designed. So the last talk is by Dr. Dheera Sandaria. I hope I am pronouncing your name correctly.
Yes, ma'am.
She is a consultant gynecologist and urogynecologist at Jaslok Hospital and Bhatia Hospital, Mumbai. Scientific coordinator in Conference Urvashe. Guest faculty at Gynicon 2023 and 24. She has many publications to her credit, and she has an interest to develop a dedicated team in urogynecology and pursue it as a specialty and be instrumental in improving women's health. So I think you will go on the path that was shown by Dr. Raja Maheshwari. So best wishes to you, and we are eagerly waiting to hear you.
Thank you, ma'am. Can you hear me? And is my screen seen, ma'am?
Yes, yes.
At the outset, I would like to thank ICOG for giving me this opportunity to give a talk. And I've thoroughly enjoyed all the sessions today, listening to all of my mentors. It's been an honor. What is vulvodynia? In 2015, three eminent societies came together to develop a consensus regarding the terminology. They divided vulvar pain into two categories. One was vulvar pain caused by a specific disorder, and second being vulvodynia, which is defined as vulvar pain of at least 3 months duration that has no identifiable cause. Vulvodynia can be classified based on the following methods. One, based on location. It can be either localized, either vestibulodynia or clitorodynia, generalized or mixed. Based on provocation, it can be provoked, spontaneous or mixed. Onset, it can be primary, that it's been there from the beginning. Secondary, it wasn't there initially, but has come up lately. Based on the temporal pattern, the timeline, it can be persistent, intermittent, constant. Immediate, that is symptoms immediately occur after the physical contact, or delayed, symptoms occurring after a gap of contact. Vulvodynia is quite prevalent. It would be, the prevalence is around 3 to 15%. The localized type, the localized vulvar pain syndrome, is the most common subtype. Also, vulvodynia happens to be the most frequent cause of dyspareunia among premenopausal women, with a prevalence of 12%. However, assessing prevalence is challenging because many women do not present for evaluation. They do not come up with their symptoms or clinical features. Often they are misdiagnosed, underdiagnosed, and they also come up with heterogeneous presentations with other chronic overlapping conditions. What is the pathogenesis? The etiology and the pathogenesis is not fully known. It is not fully known. It is most likely multifactorial. But there is one common hypothesis to all the contributors, is that there is an inciting event such as infection or trauma. This leads to a local inflammatory response. And in susceptible women, this local inflammatory response leads to a proliferation of nerve fibers in the vestibular tissue, which lowers the pain threshold, and this leads to central sensitization of pain. The contributors can be either, as we said, the first one, infection or trauma, inflammation, neurologic proliferation and sensitization, genetic factors, allergy, hormonal factors, myofascial, or it can even be psychological dysfunction. We'll just deal with each of the contributors briefly. In inflammation, there can be an excessive or abnormal immune response. What is seen that there's an increased production of pro-inflammatory chemicals, or there's limited ability of the tissues to clear the inflammatory response. This sensitizes the neurons in the vulvar vestibule and causes upregulation of the neurons in the CNS. And there have been studies which support this theory by seeing that there is an increase in the inflammatory markers such as interleukin-6, interleukin-1, and tumor necrosis factor. Second contributor in the process could be neurologic proliferation and sensitization. The supporting the supporting evidence to this theory would be there is increased density of intraepithelial nerve fibers, increased vanilloid receptors, that is the VR1, and there's hyperesthesia. And all of this result from the sensitization of the peripheral and central nervous system. There is reduced sensory and pressure pain threshold. Chronic inflammation, again, leading to hyperinnervation and sensitization, to the level that even light touch to the vulva transforms into a significantly painful response. Third factor would be infection. There have been studies which have shown an association between genital infections, especially Candida, candidiasis, and bacterial vaginosis with localized vulvar pain syndrome. There's the risk factor increases with increasing number of pelvic infections. The non-immune contributors to infection would be increased host susceptibility, altered vaginal microbiota, altered chemical metabolites produced by the disturbed flora, abnormal pelvic floor muscle spasm during or after infection, and early central sensitization of pain. In genetic factors, due to genetic polymorphisms, again, the following processes come into play: impaired immune system response, decreased ability to terminate the inflammatory response, increased susceptibility to pain, and which produces a more severe inflammatory reaction due to genetic polymorphism. Allergic reactions have also been shown to be associated with local vulvar pain syndrome, and the supportive evidence is that in patients with elevated IgE levels, when they were treated with antihistaminic medications, half of them were successfully treated. There was another study where when they examined patients with vulvar pain syndrome, they found increased immunoglobulin G positive plasma cells, which again go in favor of allergy being an etiological factor. Hormonal, the impact of hormonal the impact of hormonal evidence is not clear. There are studies which have reported increased levels of estrogen receptor as well as decreased. Also, data on the impact of contraceptive hormonal pills and development of vulvodynia are conflicting. Pelvic floor muscle dysfunction can exacerbate symptoms. There are pelvic myofascial disorders or pelvic floor hypertonus can develop in patients with vulvodynia because of the contact with the vulval vestibule, and this can lead to pain. This in turn triggers a reflex contraction and result in increased tension in the levator ani and other pelvic floor muscles. Psychological dysfunction, the association is still debatable. Coming to the diagnostic criteria, vulvodynia continues to remain a challenge with respect to diagnosis as well as management, but and hence they have come to this criteria so that we don't miss out any patients. And what does it include? Pain localized to the vulvar vestibule with or without the clitoris, absence of any identifiable cause, duration of at least 3 months, and pain elicited with pressure point testing. Vulvar pain of known etiology and localized vulvar pain syndrome can often coexist. Here we are seeing, for example, the overlapping vulvar pain syndrome conditions could be lichen sclerosis as seen in picture 1, or we have to rule out even any herpes genitalis as seen in the second picture, or candidial infections. These are typically identified when their vulvodynial symptoms persist even after treatment of all the known causes of vulvar pain. Clinical presentation, yes, the hallmark of vulvodynia is pain, pain, pain. Hallmark symptom is significant pain upon contact with the vulvar vestibule, pain otherwise with vaginal intercourse, tampon insertion, tight clothing, prolonged seating, biking or other sports. Pain onset can be immediate or delayed as we saw in the classifications. Most commonly, women affected are between 20 and 60 years of age. Diagnostic evaluation, we have to go with detailed history, physical examination, and a very important purpose of evaluation is to identify any potential known specific causes, like we can genitourinary syndrome of menopause or any local infection. History, we have to review, we have to have a comprehensive review of the systems, not to rule out the known causes, detailed gynecological history, vulvar pain history to characterize the pain and rule out other causes. The below examples are some of the other causes of pain with different etiologies, and this is just a small list. Under each etiology, there can be many more causes. We always have to rule out history of any prior skin disorders, allergies, take a detailed history of their diet, any topical treatment history, any irritants, any genital infection, their sexual history, pelvic floor dysfunction systems like urinary and bowel symptoms, any trauma or genital surgeries, the psychosocial impact that this disease is having on them, any history of dyspareunia, myofascial pain, their menstrual history, any tampon use. On the right, you will see this is a pelvic pain assessment form which is developed by the International Pelvic Pain Society, where it's an exhaustive list of their symptoms and their inciting factors and relieving factors, which help us to treat them better. What we can do is when the patients come to our clinic, we can ask them to fill this out so that when they enter the clinic, the session with them is more useful for them as well as for the clinician. Pain, since pain is the hallmark symptom, it has we have to go in details of it regarding the description, the type of pain, the location, the intensity, as well as the timeline. In the same pelvic assessment form, we have this page with the figures in it where the patients are asked to mark out their pain points to understand it better. Because when they say that it's between this level to this level, there can always be a miscommunication or misunderstanding. So when they mark it out, we know that this is the region of pain that they are mentioning. Also, we have to always ask them if they're avoiding or no longer performing any certain activities because of their symptoms, and how their symptoms impact their relationships, because by this we know what is the impact vulvodynia is having on their life. Coming to the examination, inspection goal is to identify, rule out other causes. We have to inspect all the areas of the vulva, go in order from the mons, the groin creases, labia majora and minora, the clitoris, urethra, the skin glands, the Bartholin glands, the lesser vestibular glands, the perineum, and the anus. Look for ulcers, rule out any ulcers, plaques, fissures, or excoriations. Always inspect the vestibule from 4 o'clock to 8 o'clock position along the posterior fossa, because there's very often redness seen in cases of vulvodynia. If necessary, if we see any of these lesions, we can perform a tissue biopsy to rule out any skin disorders, rule out herpes infection, and if there's any episiotomy or surgical scars, look for any area of granulation or scarring. Palpation, again, since the cardinal symptom is pain, even the cardinal sign is significant tenderness upon point pressure testing of the vulvar vestibule. Point pressure testing is done with a Q-tip in a circumferential or paintbrush pattern around the vestibule. We start from the 12 o'clock position and finish at the level of 11 o'clock position, and we mark it out on a paper so that it's easier to understand and even correlate when they come back for a follow-up. Pain out of proportion to the pressure from the touch of the cotton swab, particularly in the areas between 4 and 8 o'clock. As we see, even the redness is very common in the 4 to 8 o'clock position. If the patient is able to tolerate, the light touch, we go ahead and check the tenderness of the pelvic floor muscles, which can represent vaginismus, myofascial pain, or interstitial cystitis. A bimanual examination is done to rule out any pelvic causes of pain, like uterine fibroids, endometriotic nodules, or cysts. A speculum examination, smallest size of speculum to be used because they will have pain, to again rule out any genitourinary syndrome of menopause or rule out infection. Lab evaluation is not so much, but we can do microscopy of the vaginal discharge to look for the organism, or we can do a urine routine and culture to rule out a urinary tract infection. Imaging again would be to rule out other causes of pain and not to diagnose vulvodynia. Diagnosis of vulvodynia as a clinical diagnosis. Your supportive history would be description of a burning type of pain, inability to have vaginal intercourse or use a tampon, and interference with relationships and routine activities. As we said, there can be common overlapping syndromes or conditions, and the common associated pain syndromes, most common are fibromyalgia, interstitial cystitis, and irritable bowel syndrome. Treatment still remains a challenge. And we have to explain to the patient that there can be periods of remission and flare. It's not necessarily 100% curable at one time. We have to set realistic expectations and goal. And we have to ask the patient to be patient. And that it's a trial and error method that would suit them. First is the behavior modification. One is vulvar hygiene, good hygiene. Avoid applying soap, fragrance, or any irritants. The ACOG guidelines propose something that they call as gentle care of the vulva, and that involves wearing non-constrictive cotton underwear during the day and to avoid while sleeping, avoiding tights or tight underwears, using mild soap for bathing and only water for cleansing the vulva, avoiding any deodorants, any chemical irritants, or using only water-based, non-scented, non-allergic lubricants, or applying cool gel packs to the vulva before or after intercourse, and avoiding activities that place direct pressure on the vulva, such as bicycling. Symptom relief would be they can take soak in warm baths, such as either Epsom salt or colloidal oatmeal. Reduce stress, lubricants which can be topical or moisturizers, and avoid irritants. Exercise will help to reduce anxiety. However, avoid exercise which will cause irritation of the vulva, like spinning class or bicycling. Take a low oxalate diet, that is limit nuts and red meat. Second treatment would be the pelvic floor physical therapy. Since many of the women exhibit trigger points, they benefit with pelvic floor physical therapy because it restores muscle length as well as reduces the tension. Various techniques are used by pelvic floor physiotherapists, which include mobilization, stabilization, internal and external release, and biofeedback. Psychological intervention would again involve counseling of the patient as well as the couple. Medications, they can be topical. A lignocaine ointment has been tried, but it's only for short-term use, 2% or 5% ointment, and it can be used short-term before or after intercourse if the pain is limited during that time. Topical hormonal cream, data are still inconsistent, but people have used topical estradiol cream. Oral medications, Antidepressants like TCAs and SNRIs can be used. We have to remember whenever we start any of the antidepressants, we have to start it at a low dose and titrate it slowly. Neuropathic pain agents have been very useful, especially like gabapentin. The dose can be anywhere between 100 to 3,600 milligram per day. Again, start it at a low dose and then we can titrate it. Antifungal therapy, as we saw an association between candidal and candidal infection and vulvodynia, even antifungal therapy can be given. Vaginal prastone, that is DHEA, is used in treatment of moderate to severe dyspareunia, as this is even used in genitourinary syndrome of menopause. Other drugs are osfemifene and capsaicin, but not often used. Injectable would be Botox. That
Mom, sorry to interrupt you. Your time is up.
Yes, I think this is the last. This is the last slide. Yeah. The other treatment that is used is the Botox injections, which is given for chronic pain. We have to remember that these injections are to be given laterally and not anterior or posterior. Steroids have been tried but not regularly used. Alternative therapies can be hypnosis and laser and energy devices are under research. Thank you.
Thank you, Dr. Thira. This is a subject which is very less understood, and we fail to, give proper treatment to the patient because of this. And sometimes their symptoms actually disappear all of a sudden as it starts. So it is very distressing for the patient and causes, relationship problem also among the couple. So you've dealt the condition very nicely. So congratulations. And thank you once again, ICOG team, for giving me the opportunity to chair a session on this very prestigious course.
We immensely thank the chairpersons, Rekha Jha Madam, Leena Nair Madam, Bharati Maheshwari, and also the speakers for their crisp and excellent talk. Karishma Daryani Madam, Ramani Devi Madam, and Deera Madam. And now we have another talk by Professor Mandeep Pal, sir. Is sir online to give a speech on how to assess a woman with urinary problems. Mandeep Pal, sir.
Dr. Meena, please introduce Dr. Mandeep Pal.
Yes, madam. Yes. Can you please share the CV of Mandeep Pal, sir?
Just a minute, ma'am.
Yes. Can you please stop sharing, Dr. Deera?
Madam, I don't have a CV of.
Yes, we have Professor Mandeep Pal, sir. He is the Principal, College of Medicine and JNM Hospital, Kalyani, West Bengal, urogynecologist and pelvic reconstructive surgeon. And over to you, sir, to present on how to assess a woman with urinary problems.
Sir, slides are not audible actually.
So we can't hear you, sir.
Now, can you hear now?
Yes, sir. Yes, sir, we can hear you. Please go ahead.
Yeah. Can you see this one?
Yes,
Can
sir.
Can you see my slide?
Yes, sir. Yes, sir.
Sir, we can see the slides, but it's not audible.
Sir, is it a pre-recorded PPT?
Yes. You can't see this.
Yeah, but your
Now we can hear you.
Audio, we can hear you, but this your audio in this presentation is not audible. So better you only speak now.
Okay, okay, okay. Just see. Then ICOG team, you have my one PPT slide. Can you just share that on I speak? Hello.
Yes,
Hello,
sir.
IT support, please.
Yes,
If
yes,
you
ma'am.
can share his PPT, please share it.
I speak.
You can start now, sir.
I need to.
Yeah, yeah.
Can you see this slide?
Sir, if the slides are visible, please start.
It's visible now?
Yes, sir, it's
Yes, sir.
visible. So please speak.
Yeah. So actually, what is LUTS? Can you hear me now?
Yeah,
Yes, sir.
clearly.
Yeah. But this slide is not moving. Just a second. Oh, yeah, moving. So initially, we know that the LUTS is a Laurent urinary tract symptoms which can cause severe problem to the many women. So, but to approach this, first of all, you need to have very good diagnosis. As you know, to reach the diagnosis, the history contributes 50% of the diagnosis. So proper history is a very important aspect. Next 25% comes from the examinations, and the next 20% from investigation. So this means that 100% of the diagnosis. So you can understand that what is the importance of the history, good history taking. And this is all these my slides will be under the as per the European Association of Urology 2024 guidelines. And there also this is the recommendation is the good history taking has a very strong recommendations. And for having a very good history, is always better to use some standardized questionnaires. ICIQ have very different questionnaires depending on your type of the symptoms you are handling. We can go for different ICIQ by the British Urological Society. Then urogenital distress inventory symptoms. Then incontinence symptom questionnaires, ovarian bladder symptom score, etc., etc. So I just said this is YBSS one. YBSS is one of the very popular to diagnose the ovarian bladder symptoms. It is total 15 marks are there. Less than 3 means no ovarian bladder. 3 to 5 mild ovarian bladder. 6 to 11 moderate OAB. 12 to 15 is the severe OAB. Same here you see using validated and appropriate questionnaires, very strong recommendations. Next is we should look after the any associated medical disorders in the inquiry. Why, many underlying disorders which may have some problem and ultimately coming out as a urinary problem. Say many diabetes, multiple sclerosis, stroke, lumbar disease, etc., etc. Also, the drug side effect. Drug side effect is very another important part because sometimes many women, they are very elderly and they are taking many drugs from before that. So if there is any unknowingly, we may do not know that drug side effect is a urinary problem. Surgical history, very important. Surgery in the pelvic floor can have some problem with the blood nerve supply, ultimately causing the urinary problem. Mental health, many times we ignore this part, but there's sometimes the unexpected death of spouse or family member or other close loved one, as well as even the issues in the workplace or in the family life also can give us to some urinary problems. Examinations, like any other disorders, we do thorough examinations. Out here give some special importance like obesity, because obesity can lead to the SOI. While doing examinations, in a nulli gravida, you are finding a striae albicans. You should think that there is some underlying the collagen disorder may be there. While you are doing examinations in the spine, if in a spina bifida sometimes leads to the urinary problems. Another very important aspect is the joint hypermobility symptoms, because this is due to some underlying collagen disorders, and this can be assessed by some Bayton score, and by which you can diagnose the benign joint hypermobility syndrome, Marfan syndrome, Ehlers-Danlos, Autism spectrum, etc., etc. This is the Bayton score. You can just see here that this side is the different maneuvers we are doing. This is the histories we are taking. Out of that, they reach 4 or more points in the maneuvers and have pain in the 4 or more joints for at least 3 months. And also from here, 2 points in favor of this ultimately give a positive score to the Baton score. Coming to the examinations, while we are looking at the external urethral matters, normal diameter is 6 mm, but if you find some urethral prolapse, there is a pinkish color urethral mucus prolapsing through the UM, then some problem is there. This urethral caruncle, you see, this is the red one structures. So sometimes find these P shapes. These are known as the urethral caruncles. You may find out like this, some little protruded area just above the sulcus. It was a sulcus on the either side of the midline of this urethra. These are the torn puberethral ligament. So there is a possibility of the urinary incontinence, stress incontinence. Also, if there is the obliteration of this, normally this is present. This is a normal one in this case, but sometimes this get obliterated. In those cases also, you may think that underlying stress incontinence may be present. Yes, sometimes patients tell us that C-section is a urinary problem, but actually when you do speculum examination, you will find there's a mucovaginal discharge. So ultimately the whole diagnosis becomes different. Yeah, this is another aspect which we should always look at if there is someone coming with the pelvic organ prolapse, and we should reduce the prolapse and find out that there is no occult urinary incontinence. That means after reduction of the prolapse, urinary incontinence develops. Pelvic mass, yes, sometimes this kind of pelvic mass, they can give pressure to the bladder and cause frequency, other symptoms can occur. Senility, as you know, once they reach to the menopause, estrogen deficiency occur. So the problem may be due to that. So if you take care of that, no problem there. Neurological evaluation, bulbocondylar reflex, just put your finger over this, the clitoris, do gentle message, and look at the anus, it will move. Or you can either stroke over the labia majora, look at the anus, it will move. Anal reflex, nothing but stroke around this perianal area and look at the anus. If this moves, that means the intact neurological innervation here. We look for the muscles, the levator and a most important one, and we look for this tone and other things. From this side, come toward this side, sweeping one, and look at this. You can use the modified Oxford scale, LACOX. 0, there is no contractions. 1 is flickering of movements. 2 is a weak movement. 3 is the moderate movement. 4 is good, means they can even lift your fingers, and 5 is a strong, even they can squeeze your finger. Sensory functions, actually you take some, say you can say earbud or something, you can take, say, break in the center. So there's a rough area you can use for the pinprick, and the soft area you can use for the touch sensation, and dip it some in the alcohol, it uses the cold sensations. What you look for, you can look for the mons pubis and the upper labia major for the L1-2, perineal and the perineal skin for the S2-4, front of the skin knees for the L3-4, and the lateral part of the feet for the S1. Then we need for the look for the motor functions. Here we again use the Oxford scale of motor functions. The 0 is the no contractions, 1 is the visible contractions, but no movements. 2 is the movement with the gravity eliminated. 3 is the movement against gravity only. 4 is the movement against gravity with some resistance, and 5 is the full movement with full resistance. And what we'll do in the ankle, we do the dorsiflexiones, taking care of the L4-5, plantar flexion, taking care of the S1-2, knee joint flexions, saying us about the L5 to S1, extensions L3 to 4, and hip joints, and we are seeing just this is the reverse. See here, what is the flexion? The same number we are getting here for the extension. What are you getting the extension? Almost nearer to these flexions. Yeah, stress test, you can look for either cuff or the valsalva, and you can see here that you can do the inspections. By inspection, you can see that it's really coming or not. You can do the Q-tip test. Just put a cotton tip swab inside. Just pull it out and keep it at the blood and neck. And resting heart is this, whatever it may be. But on the straining, either valsalva or cough, the range of movement should be -2 to +30. This is plus, this minus. So -2 to +30 degree is the normal, but beyond that is abnormal. So urethral hypermobility will be present at that time. You can do the Bonis test. You just put your finger on either side of the urethra. Don't compress the urethra and put it upwards and forwards. And there's nothing but you're trying to restore the posterior urethrovesical angle. And previously, without doing, see whether incontinence present or not. After doing this one, if there is no more urinary incontinence, that means the urethral hypermobility is present. The modification of this is the Miyazaki-Bonis test, where we are putting this one is inside the urethra, the cotton swab at the level of the blood and neck. And again, you're putting the 2 bigger size of the cotton swab laterally to approximate the anterolateral vaginal wall to the pelvic side. That's why I try to restore the defect over here. and then you are asking her to strain. And then this one, this one, keeping pressure over there, so that the range of movement remain within -30 to +30. This is range movement. So whatever pressure you are giving, this is helpful when you're doing subsequent surgery or others. This much pressure is needed. With that, whatever is secured, so it's a good secure afterwards. You can do for the interstitial deficiency, you can just have this 8 French Foley's catheter, inflate the balloon and pull it out. If you can bring it out, that means the totally the this thing is your urethral incompetence is present, interstitial deficiency is present. For the fistula, we can do for this Mars 3 swab test. I think already been described in the previous one. Just a reminder that you can put 3 swabs over here and put the methylene blue inside, ask her to roam around for 10 to 15 minutes. Then again lie down, take out 3 digits out. Topmost one soft but no staining. So ureterovaginal fistula. But if it is soft and the stain also, so then it will be your this thing, high vaginal fistula. If it is median is the VBF, and the last one soft and is no staining, so ureterovaginal fistula. Dye test, nothing but without putting the dye, without putting the proton swab, it's simply directly look at it. Investigations, actually there are many instruments are there, but we should know which to be done, which not to be done. And then here initially we should do a 3-day bladder diary. That means nothing but we are seeing that how much their slide is not moving. How much these few points are there, how much they are taking. This is times in hours and in amount of fluid or water and then amount of urine pass, how much leak and amount of the leak, reason of leaking, and any urge is there or nocturnal enuresis. 3 days is good, but nowadays in the consciousness coming out, 2 days is enough. Even sometimes people think 1 day is enough because of the compliance of the patient. But in standard is the 3 days is better. This also the UUS says that bladder diary should be there is strong evidence. And regarding the urine analysis, very important part for, in fact, for my all patient, I rule out the UTI first, then I go for the any other treatment. I feel like to do this one. And the US said it is a very strong evidence to do this one first, urine analysis. Then the PVRU, very important. Ultrasound method is better. Normal is less than 50 ml. But if it is more than 100 ml, definitely it is abnormal and we need to do some thing to get rid of this. Otherwise, she will come back to us again and again with some symptom. You are going to say that yes, portfolio is very should be done. Strong evidence. Pad test, yes, you can ask her to put a pre-weighted pad and she will walk around or do some exercises for 1 hour, then weigh again. 1.4 gram or more, it shows significance of the incontinence is there. If it is 24, you can do it. So 4.4 gram or more is significant. You also say that yes, maintaining standardized protocol is needed. So it is strong evidence is there. Ultrasound, yes, definitely you can do the transvaginal, transcatheter, perineal, transcatheter ultrasounds, and we can assess the different parameters, say, for example, the bladder neck mobility or descent, uretrovesical angle, urethral rotation, etc., things we can look for it. But regarding the MRI, the very little evidence support the little use of this MRI. Yes, time is up. I think also I'm also up. Yeah, this is the second last. Urodynamic study can be done, but not routinely. Actually, for the routine SUI, no need to do urodynamic. Uncomplicated non-urogenic OAB, no need to do the urodynamics. You can totally well do the normal things. Then the coming to this slide is not booming. Anyway, coming to the cystoscopy, no need to do for the each and every patient. But if you're suspecting some hematuria or you're suspecting some CA bladder and other those things, in that case you should do this one, the cystoscopy. I don't know, slide is not moving. Yeah. And time is also up. My last message to all of you that see here also that strong evidence that uncompleted don't do, uncompleted OAB also don't do it. Cystoscopy, the hematuria, suspected carcinoma, stone, polyp, anomaly, diverticulum, etc. Those times you can do this one. Yeah, nowadays some people are telling about this urinary biomarkers, the new coming up, NGF, BDNF, prostatectomy, those things are doing, but not in routine practice, still in a research area. Yes, they are still don't do it routinely. There is also strong evidence not for doing routinely. So the conclusions, the proper history taking, thorough examination, relief investigation in a structured manner is important with validated structural question properly in the local language. Acute medical disorder and external medical administration incontinence should be ruled out. And during examination, special attention should be paid towards the neurological evaluation of the pelvis, joint hypermobility, spinal deformity, obesity, etc. Miyazaki Bonish test, pediatric Foley test is a very good armamentarium. After ruling out the urinary tract infections, still urinary persist, we should do the different investigations whichever needed. And organized approach will be very much needful to diagnose the condition properly. Thank you. Thank you very much.
Thank you, sir, for that battery of investigation to find out the cause of the problem. You've taken us through the whole gamut of the investigation that is available to us. So thank you very much for that detailed presentation.
Thank you.
And I think this brings us to the end of the ICOG certification course on urogynecology.
Yeah, thank you,
Dr. Meena.
Meena Madam, Bharati Madam, Rekha Madam, and also the speakers, Dr. Karishma, Dr. Veera, and Ramni Devi Madam. Excellent sharing and also the excellent speakers. Now I request Vidya Dobi Madam to give the closing remarks and also the ICOG team to post the post-test MCQ.
First, let us finish our post-test. Most of the people are waiting for that. Then we will have a closing remarks. But I thank Dr. Mandip Pal for waiting so long, and his talk was excellent. It was to happen the other day, but it was because of paucity of time, we could not. So the post-test is shared in the chat box. Please attempt to the post-test, as well as you can scan from this, or you can just click on the chat box, the Google form. Anything would do. And for any of your queries of not receiving certificates or anything, please mail to the ICOG office. And then somewhere you must be short of 1 day short, 1 day attendance or something like that, so that you have not received the certificate. So we will check it at the ICOG office. There are many queries about not receiving the certificates.
If everyone can switch on the camera, we could take a group photo.
After they finish the post test, they are busy in putting the post test. So later on, let them do that. Dr. Kanaklata and Dr. Shubhalakshmi are the first to submit. 5 minutes left, 5 minutes, 15 seconds. Those who want to counter check their answers can wait because we are declaring what are the answers after the finishing the post test. These lectures gradually will be uploaded on the website, so please visit website. The next ICOG certification course will be declared soon. We'll let you know. I want maximum feedbacks to the ICOG mail, whatever you feel to make it more better than this. Feedback to be put to the ICOG mail. Nilima, please put the ICOG mail ID as well in the chat box. Two minutes, 25 seconds left. So mail ID has been put in the chat box, icogoffice@gmail.com. You can send the feedback to this mail ID for about this course. Certificate will take time. It may be around 15 to 20 days or so. So that will be mailed to you.
Can you share the day 3 MCQ's answer, Nilima?
Yeah, she
These are
has
day
shared now, and just I'll go through the answers. And these questions have been put by the speakers and even the answers according to the reference. So the first one is following statement is true about the bladder pain syndrome.
I think this is the first is
Madam, this
question
is
and
day
answer.
one.
I have day 3. Yes, yes. Please put up day 3 MCQ.
Yeah, please put day 3 question answer.
Yeah. The first MCQ was the injury to the urethra or bladder during vaginal dissection can be avoided by. The second is the right one, that is infiltrating the anterior vaginal wall with the normal saline. That is the right answer. The second question is intraoperative cystourethropy is always indicated to rule out urethral or bladder perforation. The right answer is whether the sling is placed through retropubic or the transobturator approach. Recurrent UTI is 3 UTIs in a year. Lower
Lower tract
Lower tract UTI is defined as cystitis. The fifth question is integral theory for stress urinary incontinence was proposed by Petros and Ulmilston. Oral drugs are mainstay of therapy for overactive bladder. The ureterovaginal fistula can occur following LSES true. Which of the following is most common type of obstetric fistula, that is vesicovaginal fistula? Vulvodynia is defined as a vulvar pain of at least 3 months duration that has no identifiable cause. Which of the below does the criteria for localized vulvar pain syndrome not include, that is the presence of an identifiable cause? Which of these is not seen in post-PECT FOGSI case, that is buttock shooting pain? Which of these is not procedure for vaginal agenesis, that is pectopexy? Overall risk of OIC is 1% of all vaginal deliveries. What should be the angle of episiotomy to prevent OIC? That is 60%. How many major urogynecology cases per week should be performed to maintain competency in clinical practice? That is 1. What is the minimum duration of training which is required by OBGYNs to be certified as a urogynecologist subspecialty? That is minimum 3 years you have to undergo the training. What is the most commonly used autologous sling for SUI? That is rectus fascia. Traditionally, autologous rectus fascia pubovaginal sling was applied at what level? That is bladder neck and proximal urethra. Conservative management of BVF includes all of above, that is prolonged catheterization, electropulgration, laser ablation. So all of above. And the last question is the post-hysterectomy 1 centimeter fistula on the posterior wall high above trigone is best repaired by Ladsko's vaginal repair. Okay, so it is all questions and their answers. You can recheck your score. So thank you all the delegates who have joined all the 3 days. Though the registration were more than 1,000, only 200, 300 they attended. Might be their floating population that we will check, but they attended very means attentively. Okay. So ICOG team wants to take your photo. So make everybody their video on, please. I can see many of my friends here. So thank you very much, everyone. Yes.
Thank you, madam. Thank you, Dr.
Thank you
Meena,
to
who worked
ICOG
a lot.
also.
All the chairpersons, Leena
Yeah.
Di, Archana Di, they are from my society,
Yeah.
Bhagwati Society. Dr. Meena has worked a lot. For taking today.
Congratulations, Kavita, for that
Yeah,
excellent
thank you for
ICG
3-day
certificate course.
urogynec and general surgery. So I think
Sumandi also.
everyone has worked a lot, including me, so that it was.
No, we congratulate, and there is a vote of thanks. Please wait for that.
Yes.
So we really thank everybody who has attended all the 3 days, 1 day, 2 days, because everybody is busy. But this branch is totally not new, but it requires more sensitization. There are many things to learn, and many more new things have come up. So right from sling, so many things have come up, and really it is a very good branch to learn. Apart from endoscopy, infertility, and the so many fetal medicine and all this, urogynecology is really one branch one should always concentrate upon. So in our postgraduate days also, it is one integral part to teach, and let us make it more popular. That's what we want. I think Dr. Kavita and Dr. Suman, both of them, they have their chairpersons, and they are taking this task again forward. And many of the so many specialties means the people have joined, even neurosurgeons and all, and the simple imaging and all. So new topics have been included. Maybe we will be bringing the checklist, and I propose ICOG as a governing council member of ICOG. Maybe we are going to bring one small book also. I have told Dr. Kavita and Dr. Suman who have joined, and really I'm very much thankful to them. Dr. Suman and Dr. Kavita, they have taken much efforts, and all the 3 coordinators. First day, Dr. Meera Raghavan, whether she had joined today, I don't know. She was the first one. Second, Dr. Niharika, and today Dr. Meena is there, Meena Mahalingam. They have taken all the efforts. I really thank our President, Dr. Jaideep, thank Dr. Madhuri Patel, General Secretary, and our ICOG Chairperson, Dr. Parul Gotradawala and Dr. Sarita Bhalerao. They have taken keen interest on taking up this certification course, and I'm seeing all the certification courses are hit. Last year I did 3 days nutrition course, but that was not much popular. The surgical branches are more popular, but I did that nutrition course for 3 days also last year. So this is today I must thank all the speakers, all the chairpersons, all the delegates. I need not take their names because definitely everybody has listened to them. And I had taken their names in the starting time only. So I thank each one of them. Thank you very much. If you have got any queries, you can put in the chat box. I'm really sorry that I disturbed the post-test flow by announcement and all. I'm really sorry if but 50% marks if you get in the post-test, you're eligible for the certificate. And you just check your score yourself, so that that will be helpful. I'm seeing Dr. Ushan here, so senior madam, but she has joined this course, and really it is very helpful, as I also have learned many things today. Dr. Chandra is there. So many my friends are, I can see in the audience. Dr. Suman, you want to say something, and Dr. Kavita also, please, because we are concluding today. So you can address our gathering. Please unmute yourself, and Nilima, please make them a co-host so that Dr. Suman can unmute, and even Dr. Kavita. Dr. Meena, you want to say something? Dr. Meena, you speak something.
Thank you, madam, for the wonderful opportunity. You had a lot of learning from all the senior faculty as well as the junior faculty chairpersons. Really had a good time exchanging knowledge, madam. Thank you for the wonderful opportunity given to me.
Thank
Good
you.
effort. Thank
Yeah.
you.
Dr. Kavita, you please unmute.
Yeah. Thank you so much, Vidya madam. So first of all, I would like to thank our President Jaideep Tang sir and Secretary General Madhuri Patel madam for giving us opportunity to conduct such a ICOG certified CME for 3 days. And I'm really thankful to Parul Kotawala sir, Chairperson ICOG, Sarita Valera madam, and ICOG GC member Vidya Thoi madam. They were very helpful during these meetings, and every time Zoom meetings, they always guided us, and we did what they advised. And I'm thankful to Chairperson Suman madam, because I was in Vadodara and she was working at the time. I had to attend another conference, so she worked a lot with me. And in fact, I and Suman madam always do together, so we have very good series also. So thank you, and all the eminent speakers, even Ajay Rani sir and Dr. Mohan, they have joined from outside, from Australia and Nepal, and all the eminent urogynecologists from our country, because we don't practice urogynecology, but I have learned many things in last 10 months. And Dr. Amita has become very good friend. J.V. Sharma sir always guiding, and many, in fact, Dr. Mandeep Pai sir, we have a book written by him. So this book is very helpful for me. So I'm thankful to all the speakers who are here. Dr. Karishma, Dr. Dheera, they are very junior to me, but they know a lot in urogynecology, and they always help me, in fact, making slides and everything. So I'm thankful to all of them, all the eminent speakers and chairpersons. Today we have some festival, we are without water, but still many of us have joined. So Deena Nadi, Archana Di, Rekha madam, Bhartima Shri, Sneha Bugar madam, all have joined. So I'm thankful to all of them. And coordinators for 3 days, Dr. Meera, Dr. Niharika, and Dr. Meena, they worked a lot. We just ask them to do these things, to contact them, but they have really worked. They are grassroots level workers. So really, I'm thankful to them. Dr. Meena, Meera, and Niharika are not being seen, but I must thank you sincerely from the core of heart. You have always worked a lot in my making the webinars and all other CMEs. So I hope the same for last again for the future.
Thank you, Dr. Kavita. And I just want one of the
Madam.
delegate to speak.
Madam, I'm there, madam.
Yeah.
And IC office also, ICG office, Nilima and others.
Nilima has, and Purnima and all ICOG IT team has worked very hard to make it successful, I must say. I want Dr. Sameer Pradhan to tell, because he was a delegate also, and he was a faculty also. Even Dr. Monica Gupta has joined, and I really thank you very much for them. I want him to speak. Yeah. 2 words.
Thank you so much, madam. It was a great learning over last 3 days, and all the talks were so excellent. Like recently, I have written a chapter on OAC, obstetric anal sphincter injury, which I had given to Dr. Suman Sinha madam for the AICOG, which is going to come at Mumbai in January. But still, today's Dr. Ramani Devi's talk was so enlightening. I could add more points to my already existing knowledge. So what I say to all my friends and who take advice from me is, learning is a continuous process, and you can always compete with yourself and upscale your own skills and do the best for the patient. Other thing which I always, I'm a part of this FOGSI group. In fact, I'm the joint secretary for Maharashtra, but equally I'm also do conventional surgeries and laparoscopic surgeries. What I see is sometimes there is this, in this conferences, there is this partition. I am only a endoscopic surgeon, I am only a vaginal surgeon, and people are quite dogmatic about it, and I can do this. So what I wish to tell the juniors is we are here to take care of the woman, and whatever is the best in our armamentarium, we should give them the best. Like if the patient has multiple fibroids and it is a big size uterus, abdominal hysterectomy still has a role. One need not spend 4 hours doing laparoscopy and cause parasitic fibroids. At the same time, if there is a deep infiltrating endometriosis or a ventofix uterus, one should not attempt vaginal surgeries because it will cause complications. So that is very important. One has to keep on learning and do for the betterment of the woman. Thank you.
Thank you very much. Thank you. Any other person, any other delegate, they want to speak, they can unmute themselves and they can, anybody? Yes. Thank you very much. Dr. Monica, are you there?
Madam, they have kindly tell them that they should give a feedback.
Yeah, no, I have written in the chat box. Dr. Suman, you want to speak? Please speak.
Everybody has already spoken so much. I'm really thankful to each and everyone.
Not about Thanksgiving. We have enough. We have thanked everyone. I want to comment about the course and all.
The course was really very insightful. We learned so many things. Apart from vaginal surgeries, I can learn so many things from urogynec committee. And really it is helpful clinically. It will come in our day-to-day practice. Even if you don't do, you can refer to the right person who is doing it. This is also very important because each and everything cannot be done by one person. So this is also an important thing to know. And all our speakers were too good. Even today, all 3 days, all excellent speakers were there. And such a lucid presentation, and everything was practically based. This is very important. And even so many people had registered, so many delegates registered. And even if the 200 something, 230 have attempted the post-test, that is also very good. Because many of them, even they don't want to attend all 3 days, because for the post-test, all 3 days is important. And for everybody, it is not possible. So who is destined to give the post-test, they will only join for 3 days. Otherwise, if somebody has attended even 1 day, that is sufficient. Because every day there was knowledge sharing. So thank you very much. And Bidatavi, madam, you're really wonderful. You supported it because this was our first experience. And if you're not here, we couldn't have done it. I'm very frankly, I'm speaking. So lot of thanks to you for your support and encouragement.
Thank you very much.
I had to say.
Many more programs, and I must congratulate both the chairpersons of our FOGSI. They are taking these committees to their next level. So all of us are learning and relearning. Nobody is great, nobody is down. As Samir was telling, that we are learning with every day is learning for us.
We need everybody's encouragement and support, because my committee is a very new committee. I don't have any mentor because it is only 9 months.
Do much more work in future also. Definitely.
Good evening, Dr. 9 months old. Whatever I could do, I'm doing. Thank you.
You will do it.
Good evening, Dr. Vidya. I want to say a few words.
Yes, definitely, Dr. Chandra.
Yeah, it's a wonderful thing. We learned a lot. After practicing for more than 3 decades, we learned a lot, and it was a motivating thing. And you made it, what to say, not to tell anything, because all your speakers who you selected, no, everybody gave their excellent presentation, and we learned a lot. And it should be the prime for the youngsters. Instead of going and sitting in a lecture, from their house itself, they are learning. So it is the gift what COVID gives us. So I think like that only. Thank you very much, and it should go on forever. Thank you.
Yeah.
Thank you. Thank you.
Thank you very much. Thank you. So we will end our meeting now, and let us move forward. Visit